steal one of these. All right, good morning. We are live for class 5. How's everybody doing? Any questions? Anything I can help you with? Go over? Everything going good? Okay. Let me go ahead and get your scores for chapters 5 and 6. And I know that we're waiting on several, so I'm just going to go through this really quickly here. Brianna, Natalie, thank you. Katie, Cody, thank you. Thanya, Elena, Haley, August, Justin, Holly.
100 on both.
Okay. William, Brandy, Special, and Harmony. All right. If anybody from class is joining us remotely, you can put your scores in the chat, and Jake will let me know what they are. All right. Oops. Oh, why won't 4 work? Huh. Jake, can you make a note, please?
Yes, ma'am.
Class 5, button 4, disconnected. Thank you. All right, so game show is tomorrow. If you haven't registered for the test yet, you probably should. This is, we do the test registration on class 4 because the timing works out really well. If you do the test registration when we give you the information, you should be testing about a week or 2 after graduation. So that timing works out really, really well. So if you haven't registered yet, you probably want to do that so that there's not a big gap between class and test. Okay. Game show is tomorrow. I'm not sure what topic I'm going to pick. I got to go home and write the questions for tomorrow. So it'll be a mystery to all of us. But if you have a chance, tune in live at 11 tomorrow for the game show. I'm going to go over 15 test-like questions, and we'll go over the answers as well. Oh, 6 is not working either.
Button 6 as well?
Yeah, I don't know why. Hopefully we won't have a problem here.
I can manually change them from my end, correct?
I believe so.
Okay. So it may just be an issue with the Stream Deck?
Yeah, well, I'll have to check it out after class. Okay.
Button 6 as well.
Yep.
Got it.
Okay, so real quick review. And I'm going to do this really quick because I want to give you guys some practice time at the end of class today. So every skill starts with the opening. Every opening starts with a knock. And then we're going, to greet the patient, address them by name, introduce ourselves by name and title, explain what we're there to do, get their permission, close curtain, wash hands, get our supplies. Big checkpoint on this one is don't touch the patient until your hands are clean. We also have to decide if we're going to need gloves. Now, the gloves aren't based on the skill as much as they are the patient, because there are some skills that you don't need gloves for, like range of motion. You don't need gloves for that. But if the patient has some sort of a wound or a rash in the area that you're going to be working at, now all of a sudden we need gloves. So gloves aren't skill specific, they're patient specific. So we're going to wear gloves anytime we're going to touch body fluids, personal skin, non-intact skin, and we want to wait to put those gloves on until we're ready to actually start the skill. So the first thing your gloves should touch is the patient. Once you've touched the patient, those gloves are contaminated. So be careful about what you're touching in your environment, and then you have to remove them properly by pinching up at the bottom of the palm and taking off and then going under. So pinch up and then under, and then dispose of your gloves. Oh yeah, C9 isn't working. Okay, hold on one second. Let me, you may have to advance these. I don't know why. I know I went through all these. Yeah, see, it's not.
Can I keep going forward ahead of them and fix them?
So the problem is,
They're not associated with the stream deck.
yep, they lost association. I know I set them up, but you may need to see. The problem is now that's what we're seeing on the screen. We're seeing this whole screen on the screen. So,
I have a solution.
hold on one second. Let me try. We got some technical difficulties we're trying to work through, so give us just a minute.
I have it. Okay, this should work. And now the problem is going to be the audio thing. I'll just switch that over to real quick.
Good solution. Look at you.
Your default, we're good there. All right, so you should be good to continue.
Speaker. Hopefully that would work.
I'll change the audio when we're ready to play a video.
Yeah, but I don't know if they can hear, and you can't see chat now.
That's fine. I can still hear and I can log.
Okay, so you can hear me?
Yes, ma'am.
Okay, good. All right. Oh, we need to know that for a update. Okay, so barrier. Let's go back to this. So barrier we're going to use anytime we use supplies. So if you find yourself getting supplies, you need a clean place to put them. And that's what the barrier does. It gives us a clean place for our clean supplies. You only want to touch your supplies with clean hands. You don't want to hold them up next to your uniform. And we always get the barrier first. Now, most of the time, the barrier goes on the table. But there are a few skills, or one in particular, that we're going to put it on the floor. And that's foot care. But most of the time, it's all just to create a clean working environment, because we don't want to put clean supplies directly on the table or on the floor or on the bed or wherever. What's next? Privacy blanket. The test doesn't, and I want to talk about this real quick. The test doesn't specifically indicate that you have to use a privacy blanket. So if you choose not to, it's, it's okay. You don't have to. And when you're watching other videos, you'll see that not everybody uses a privacy blanket. The testing checkpoint is minimize exposure. So if you're doing that with a sheet that's already on the bed, that's okay. Perfectly okay. I like to go a step further, because first of all, if you have to move that sheet, whatever body part you're exposing is going to get cold. And that's uncomfortable. And that is graded under patient comfort. So privacy blanket is one of those topics that gets a lot of controversy. A lot of instructors will say, well, it's not graded on the checklist. It's not even mentioned on the checklist. You can skip it. But we do have to understand there are some other checkpoints that may be affected if you don't use the privacy blanket. So that's why I always teach, anytime your patient is uncovered or undressed, use a blanket. That way the patient is warm and we're minimizing exposure. But if you're going to put anything on the bed, we don't snap it or shake it. And you want to put it on in a way that allows you to keep the patient covered at all times. So we put the blanket on first, we pull the sheet down underneath so the blanket is always, or so that the patient is always covered by something. Now, if we do choose to use a privacy blanket, then when you take it off, actually is going to be graded. So if you have soiled gloves on and you reach down and touch that sheet that's going to go right up next to the patient's face, you will get graded on indirect care. That also counts too if you're not using a privacy blanket. If you're touching that sheet with your soiled gloves, that's going to be a violation of standard precautions or infection control practices under indirect care. So that's why I tend to default to privacy blankets. Does that make sense? Okay. All right. Sorry, Jake, I had to advance. All right. So you're going to keep your linens and your environment clean using linen rules. So linen rules are linens can't touch your uniform. We already know that. We don't snap or shake linens. We already know that. You have to have clean hands to get your linens. We already know that. Clean rolls toward me, dirty rolls away. We've learned that too. Don't let anything touch the floor. Not clean, not dirty, nothing goes on the floor. And anything you take and don't use must be discarded. Okay. All right. Scoot and roll. Patient has to be in the middle of the bed at all times. No exceptions. You don't have side rails to keep them safe. So when you're working with a patient in bed and you have to turn them over, we're going to do this as a two-step process. Scoot them toward us, roll them away. You should remain behind your patients behind, so never turn them toward you. And our cardinal rule here is the patient must always be in the middle of the bed. So at the end of every skill that you do, when you're doing your closing, we tend to just kind of get into the rhythm and say the words, and we don't really pay attention when we're saying the words. I want you to stop and actually look at your patient. Do they look safe? Do they look comfortable? Do they look like they need anything? Watch their facial expressions. This is actually going to save you time in the long run. And I saw this happen. It was really funny because I've been preaching this for years and years and years and years. But when my mom was in the hospital, I actually saw this at work because I went in, I was going to be daughter. I'm not nurse. When my mom is in the hospital, I am not Patty the nurse. I am Patty the daughter. I can't have both roles. So I'm just sitting there minding my own business at my mom's bedside. And the CNA came in and did a couple things. And when she left, she didn't really look at my mom. She just, didn't ask, is there anything else you need? She's like, I'll be back in an hour or so. Take your vitals. And my mom just had this look on her face like she wanted to ask for something. And I didn't jump in. I just and the CNA left. So after 5 or 10 minutes, my mom is like agitated. She's like fussing with stuff. And I'm like, Mom, what do you need? And she said, well, I'm really thirsty, because she had surgery and her throat was really dry. She's like, I'm really thirsty. And the CNA just looks like she's in so much of a hurry that, okay, Mom, let me go out to the nurse's station and I'll get you something to drink. So I did. I go out to the nurse's station, get her a drink and bring it back in. And a few minutes later, she's like shivering. I'm like, Mom, what do you need? She's like, I'm cold. Okay, let me go get you a blanket. I go out to the nurse's station, I get a blanket, bring it back. And, this went on. I went out to the nurse's station like 4 times. And all I could think of is it's a really good thing that I'm here because otherwise she would have used the call light for all of it. And when you have family members there that can fulfill that role, be nice to them because they're saving you a lot of work. But if the CNA had just stopped and looked at her before she left, Mom would have asked her for a drink right then. And it probably would have saved Mom agitation, but also the CNA time. So the more stuff that you can get done when you're in the patient's room, the better off the patient is going to be. But also it's better for your time management as well. Does that make sense? So take a minute to look at the patient. I'm moving the slides, Jake.
Okay.
All right. You have it back? Okay. So washing rules. If you're going to wash anything, we do it the same way. It doesn't matter whether it's a hand or a foot or a body or a peri area or whatever. If you're washing, it's all done the same way. We don't add soap to the basin because we need that water clean for rinsing. So basins are no soap zones. When you get water, you're going to use a paper towel to turn the faucet on and check it with the inside of your wrist. It should feel warm, not hot, not cold, just warm. And the patient also needs to check it. Super important. We're going to wash, rinse, and dry. And if we're going to wash any wet body openings, we're going to use the leaves method, which we're going to learn on Wednesday. We will learn the leaves method. Try not to get your surface wet. So on the table, we have a barrier. On the bed, if we're working on the bed, we want to put something down underneath the patient to protect the sheets from getting wet. So a towel or a chucks or something. And then if we put lotion on, we always wipe off the excess. Moving, Jake.
Okay.
Thank you.
Uh-huh.
Basin cleaning. All basins are cleaned the same way. And our checkpoint is rinse, dry, and store the basin. You don't have to get all tangled up in the details, but it is nice to know how to do this if you have to disinfect later in your career. So we dump the basin wherever it would normally go, rinse it, dump that rinse water wherever the stuff went. And then if you have to disinfect, you can't hold it while you're disinfecting. So set it down and spray it. Paper towel to pick it up, paper towel to dry the inside, paper towel to dry the outside, and then one more to open the drawer because your hands are not clean. Moving along, Jake. All right. So you have to end the skill with clean hands. That is our bright light, strobe, checkpoint that we can't forget. This is the one thing that will absolutely fail you on the state exam is if you don't wash your hands after providing care. Remember that washing your hands before providing care is for the patient. That's so that you have clean hands to work with them. Washing your hands after providing care is for you because you might put your hands up around your face or touch another person or spread pathogens around the environment. So the first hand washing is always for the patient. The second one is for you and the environment. So it's super, super important that we remember this. Before we get to hand washing, though, there's a whole bunch of things we have to do. We have to make sure the patient's in a clean and safe environment. The bed is in the low position. The patient is covered. They have their call light. You've asked if they're comfortable, and they need to hear that. We want to address preferences as well. Would you like a magazine? And we're going to open the curtain. So all of those things have to be done before you wash your hands. Now, if we have to document, then we're going to wash our hands, document, and then wash the hands again because of this rule. Good? All right. See if I can do this without tripping myself. Okay. Moving, Jake.
Hold, please. One moment.
Yep.
And good.
Great job, by the way.
Thank you.
All right, pulse. Pulse is a measurement of how many times the heart beats over 1 minute. Always, always measured over 1 minute. I'm sorry. Always reported over 1 minute. I used the wrong word there. Always reported over 1 minute. Measured according to the care plan. If the care plan says 60 seconds, we have to count for the full minute. If the care plan tells us we can use a pulse ox, we'll use a pulse ox, which is that little clothespin thing. If the care plan says nothing, if it doesn't give us any indication, then we do 15 seconds and multiply that by 4 to get our reading. Normal is between 60 and 100. Anything outside of that range gets reported to the nurse. A radial pulse is located at the wrist. It's at the very top part of the wrist, near the thumb, at the bendy part, not down here. We use 2 fingers, fingertips, not flat part, and we put our thumb on the back side. For the test, you're going to have to say start when you start counting and stop when you stop counting so that they can make sure it was a full minute. And the evaluators on the other side of the bed counting as well. And we're going to see how close you are. You can be off by 4 beats in either direction and still be considered accurate. This is a documentation skill, so you have to document for this one. Is everything okay? Oh, okay. Okay. All right. So, do you get them all done, Jake? Wow. You are hired. All right. Dressing a resident. Good morning. Dressing a resident with a weak arm. The way we remember this is USA first. If the patient doesn't have a weak arm, just dress them. There's no specific way it has to be done. But if they have a weak arm, that's going to affect how we dress them. And the way you remember that is undress strong arm first, dress weak arm first. We want to ask them what they want to wear. Their clothing preference counts. We're going to get the clothing before we undress them to minimize exposure. We're going to lift from below with the flat palms supporting the extremities. Don't overextend or force movement. Make sure they look good at the end. Pants are over the butt at the natural waist. Toe seams are along the toe, not cattywampus. The shirt is buttoned or snapped appropriately. Presentation counts with this one for sure. At the end of the skill, they're dressed. So you can ask them, do you want the sheet on? Do you want the sheet off? You can ask them, but there's no requirement for the sheet because they are dressed. Okay, remember they have to be covered with something, sheet or clothing. Call light has to be in the stronger hand. And this skill, you have to kind of look around to make sure, did you leave the gown on the bed? Did you leave it on the table? This one, clean environment, actually gets missed a lot because people take the gown off, they put it on the end of the bed, and then they forget it and they don't get that checkpoint. So this is one that you really want to kind of trick your mind into look for because you're likely to miss that. Hand and nail care. This is a mini Manny. We're soaking one hand, rinsing one hand, drying one hand, cleaning the nails, filing the rough edges, and putting lotion on. We're going to wipe off that lotion. When we lift the hand, you want to support it. Don't just do a crane lift, okay? You want to support it. And anytime the hand is not in the basin, it should be on a towel. When we clean under the nails, we want to wipe it off before we go to the next nail. And when we file in one direction toward the middle. Good. This should all look somewhat familiar to you. Making an occupied bed. We're just going to change the bottom sheet a half of the time. The rest of the bed gets made like it normally does. So the way that we do this is to get your patient laying on their side in the middle of the bed. So scoot and roll so they're on their side. And then we're going to use that whole clean rolls toward me, dirty rolls away. So we're going to roll the dirty sheet toward the patient, tuck it under them as far as we can, put the clean sheet on, roll it toward me, tuck it under the dirty as far as I can, get the patient back on their back in the middle of the bed, go around to the other side, do it all again. So super easy. It's not a hard skill. It is kind of a magic trick though. It's kind of neat to learn. And then you put the top sheet on, make sure the corners are tucked. The end of the sheet is tucked under the mattress and the corners are up off the floor. Hospital corners are best, but if you can't do hospital corners, just get those corners under the mattress. Change the pillowcase last. You want to limit the amount of time the patient doesn't have their pillow. Now, there's a very, very, very old nursing principle that I'm going to tell you about this. When you put a pillow on a bed, the opening should face away from the door. It's a very old nursing principle. This is from way back in TB days, tuberculosis days, because tuberculosis tended to float in a facility. And pillows, by their very nature, tend to be warm, dark, and moist because we drool on them or sweat on them. So when air currents are able to get inside the pillowcase, it's a good environment for them to multiply. So we never wanted the opening of a pillow to face the doorway where the air currents could actually get inside the pillowcase. It was just a good nursing principle, not something that we would really think about. We don't have as much tuberculosis now as we did 100 years ago, but it is still around. And tuberculosis isn't the only airborne disease that we really have to worry about. So it's a good habit to kind of get into, that the opening of the pillowcase faces away from the door, because you never know when the next pandemic is going to strike. Okay. All right. Sideline position. This is turning a patient onto their side and propping them there with pillows. You can use rolled blankets as well. You can use rolled up towels. You can use pretty much anything to get them propped in that position. But for the test, we're going to use 3 pillows for this. So again, we're going to use the whole scoot and roll. You can ask the patient to scoot towards you for the test. But before we roll them, we want to position them properly because they can't really help us. So the best way to position somebody to roll is furthest arm up, closest arm crosses, closest knee bent, furthest knee angled out. When you do that, no pressure at all. They just flip right over onto their side. We're going to put a pillow behind their back, tuck it in, roll it up and over, and tuck it in again. That creates a really nice roll along the back. We'll come around the bed, lift that top leg, and put a pillow between the legs. Now, that top leg should be just a little bit offset off of the bottom leg, so they're not right on top. They're just a little offset. And you want that pillow, you want that pillow between the knees and the ankles specifically, okay? We're going to put the 3rd pillow under that top arm to get it in a neutral position, making sure it's not covering the face. And then we adjust the pillow that's already on the bed, the one under their head. We want to pick the head up and make sure that pillow's not under that bottom shoulder, just under the head and neck, and tuck that bottom hand underneath that pillow. Call light goes in that bottom hand so that we don't have a cord stretching across the neck. All right. Foot care, just like hand and nail care, a little bit lower, nothing with the nails. So we're going to soak the foot, wash the foot, rinse the foot, dry the foot. All of our washing rules apply here. So anytime that we get water, we check it, they check it. This is a floor skill, so we're going to put the barrier on the floor. It's a little bit different. Anytime you lift the leg, you want to lift with support. And anytime the foot is out of the basin, it should be on a towel. The whole purpose here is to look at the foot, guys. Now, these basins are not really big. If the person has small feet and you have to do both feet, do them both at the same time. If this person has big feet and both of them are not going to fit in the basin, do them one at a time. It doesn't really matter. But for the test, we only have to do one, so they're going to make this a little bit easier for us. And mouth care. Mouth care was brushing teeth. We all know how to do that. We do want to make sure the patient is in a full upright sitting position, preferably with a pillow behind their upper back so that it's not pushing that head forward. We're going to wet the toothbrush, put some toothpaste on it, and brush what they've got. We're going to let them rinse and spit as much as they need to. And at the end of the skill, you want to make sure you leave them with their mouth dry. Clean your basin up, put everything away, take your gloves off, end the skill. It's not a hard skill. It's one that most of us are familiar with. Respirations is the act of breathing. This, again, is always reported over 1 full minute. However long you have to count will be determined by your care plan. If it's not specified, 15 seconds, multiply that by 4. Make it easy. In and out counts as 1. Normal is between 12 and 20, and you don't want to tell the patient that you're counting their breathing, because if you tell them I'm counting your breathing, it alters their breathing. You're going to say start and stop so the evaluator can count with you, and this is a documentation skill. This is the most common skill on the state exam. It shows up on, I think it's 4 care plan sets. So out of all the documentation skills, this is the one you're most likely to get. It's also the easiest. Range of motion. We've learned 2, I believe, range of motions. We're going to lift from below with a flat palm. We're going to follow our care plan. Care plan is going to tell you what body part, what exercises, and how many repetitions. Just follow the instructions. Flexion extension is up, down. Abduction, adduction is side to side. Rotation is around. There are no rotation exercises on the state exam. Good? All right, so let's learn the last range of motion. This is page 80. Jake, thank you so much.
We can switch over the monitors at any time if you'd like.
Okay.
I'm still able to monitor chat as is.
Okay, good. We'll do that. Let me get through the instruction on this, and before we do the video, we can switch it over. Okay. All right. Not much to teach you on this one. I'm going to talk for 5 minutes. We're going to watch a video. Okay. Not much to teach you. We already know everything we need to know to do this. Range of motion, we have to know what body part, what exercises, and how many repetitions. This is a live patient skill. The person will be laying in bed for this skill. Page 81 has our care plan at the top of the page, step-by-step instructions. No supplies are needed. And here is our care plan. Provide the following range of motion exercise to the resident's right hip, knee, and ankle. Flexion extension. So 1 exercise. We're going to exercise 3 joints, but those joints are going to be moved up and down. Okay. Provide 3 repetitions. Resident is not able to help. So we know everything we need to know to do this skill. But I want to review range of motion real quick because there is one thing that you do need to know about exercising the hip and the knee that is a little bit different than what we've learned so far. Okay. So remember that we always support our extremity. We follow the care plan that tells us which body part, which exercises, how many repetitions. We're going to lift, holding near the joints and providing support from below. We're going to move slowly and smoothly all the way back to start. Flexion extension is up, down, and that's what we're going to do for this particular skill. There is no abduction, adduction. There is no rotation. It's just up and down. But with the hip and the knee, we're going to move both at the same time. And there's a very specific reason why. When you bend the knee up to the chest and back to the bed, okay, so we're going to bend the knee up to the chest. That bends both the hip and the knee together. We don't want to just bend the hip by itself. That would look like a straight leg raise. We don't do this. And that's because of nerves. I want you to think of a rubber band. Okay, when you have a brand new rubber band, it's super stretchy. You can pull it and it'll snap back. You can do that a million times and it always snaps back. Fast forward 70 years, what is that rubber band going to look like? Yeah, it's old and brittle and doesn't have as much stretch to it. It's just not as flexible. Well, this is how your nerves are in your back. And there's one specific nerve that we get really concerned about that runs from your spinal cord down the back of your leg all the way to your foot. And that is your sciatic nerve. That is your big nerve in your legs that are feeding information to and from your brain. Well, this nerve gets very tight and very brittle. And when you try to do a straight leg raise, it stretches that nerve and it can be very painful for patients. This is the kind of pain that if we do this to a patient, this pain might not actually go away for weeks, months, or years just from one exercise. This pain can stick around for a very long time. We don't want to do that to our patient. So instead of just exercising the hip with a straight leg raise, we're going to bend both the knee. Oops, sorry, let me go back. We're going to bend both the knee and the hip together, and that keeps that nerve from being stretched really taut. Make sense? So this kind of looks like the patient's climbing upstairs when we're doing it. And then we're going to lift the foot off of the bed just a little bit and bend the ankle forward and back. And you don't want that heel to scrape against the sheet. So we're going to lift that foot just a little bit off of the bed and bend the foot forward and back, and this flexes and extends the ankle. This is way more important than you think it is. If there's one range of motion exercise that you may be asked to do, it's this one. And that's because when we're in bed and we toss and we turn, if we're in bed for an extended period of time, you will bend your hips, you will bend your knees without really even thinking about it, because you'll draw your knees up, you'll toss and you'll turn. You'll move your arms to reach for your water, to get the call light, to change the channel. So we're kind of doing a little bit of motion as we go, but your ankles are the one thing that you don't move on your own when you're in bed. So what ends up happening is these tendons tend to draw up tight, and you lose flexibility in your ankles when you're in bed for an extended period of time. And you guys have probably already experienced this. Have you slept in, been in bed a really long time, had a lazy day, and then go to get out of bed, and when your feet hit the floor and your weight settles on that ankle, it feels tight? That's why flexion extension of the ankle is one of the most important skills that we have to do with range of motion when our patient is in bed for an extended period of time, when they're weak or recovering. Does that make sense? Okay, good. Any questions on that? Okay. Rotation and abduction, adduction are not on this this care plan, so we're not going to do those. As we're doing these exercises, we do want to ask, are you having any pain? Watch their face for grimacing, wincing. Watch their extremities for tightening up and resisting. Those are all signs that we may be going too far. We don't ever want to hurt our patient. So we now know all of the steps we need to take. Let's see how we're going to get all of these checked off. We're going to follow our care plan. We're going to do our opening. We're going to evaluate if we need gloves. You probably won't for the test, but we'll evaluate. We're going to do our range of motion skills specific steps according to the care plan, and we're going to do our closing. And all of that together will get everything checked off. Remember, this care plan is just for this patient, nobody else. So every care plan that you have will be a little bit different. Jake's going to give him about 2 minutes. He's going to switch our tech around so that he can show you this video. And we're going to move.
All right, sorry, go ahead.
Okay. So today we do have 4 skills to do. A couple of them are very long skills, especially partial bed bath. That is the longest skill that we have, along with denture care, which is the second longest skill. So we got some longer skills to do today, but I'm going to kind of get through what we need to get through quickly so that you have some practice time at the end of class today as well. All right, Jake, go ahead and take her away.
Sorry about that.
It's fine. You're doing a great job with tech.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Wonderful. I need to do some exercises on your right hip, knee, and ankle. Is that okay?
Yes.
Okay, I'm going to close your curtain. Let me go wash my hands, and I'll be right back. Okay, after washing my hands, we're ready to get started. The first exercise I'm going to do is bring your knee up to your chest and back down to the bed. I'll do all the work. All you have to do is let me know if there's any pain or discomfort. We're going to provide 2 points of support, one under the knee and one under the heel. And we're going to lift up and all the way back to the bed. Feel okay?
Yes.
Any pain?
No.
We're going to do it again. Up and all the way back. And one more. Up and all the way back. Feel okay?
Yes.
Okay, now I'm going to work on the ankle. I'm going to lift your leg off the bed just a little bit, and then I'm going to bend your foot forward and back. You should feel a little stretch. Please let me know if there's any pain.
Okay.
So I'm going to lift under the ankle. We're going to bend the foot forward and then back. Feel okay?
Yes.
We're going to go forward and back. Feel okay?
Yes.
One more, forward and back. Good?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Would you like a magazine before I go?
No, thank you.
Are you comfortable?
Yes, ma'am.
Environment is clean. Bed is in the low position. Here's the call light. If you need anything at all, just press the red button and we'll be happy to come help. I'm going to open the curtain and go wash my hands. After washing my hands, I'll review the care plan, think about my skill, make any corrections, and then tell the evaluator my skill is done. Any questions on that? That should look like a pretty easy skill by the time we get to this point. All right, so now we're going to move on to denture care. This is not so easy of a skill. If you go to page 96, it gives you your overview of this particular skill. Down the side, you can see all the principles. They're spelled out for us at the bottom of the page there. You can see somebody with your level of experience should be able to do this skill in 13 minutes or less. 13 minutes or less. This is mouth care with an extra step. So everything we did for mouth care, we're doing again, but we're adding in cleaning the dentures. So it's a much bigger skill than mouth care, but they don't give you a whole lot of extra time for it. So kind of keep that in mind. This is one that you really are going to want to make sure that you're practicing to get your time down. Everything else I've told you, got plenty of time, way more time than you need. You don't have to rush. This one, I think the timing is a little bit more compressed. It's still plenty of time. You can get it done in this time frame, but it is going to require a little bit of practice on your part to get the steps down. Make sense? Okay. All right, so if we go to the next page, page 97, you can see the care plan at the top. We're going to look at that in detail in a minute. Step-by-step instructions are on this page, and all of your supplies are at the bottom. There are a lot of supplies for this skill, a lot of supplies. But if you look at the very end, you'll see there's 2 sets of gloves that are required. This is one of, there's only 2 skills that require 2 sets of gloves, and this is one of them. So that means that there's going to be a point in this skill where we're going to have to change gloves. And this is the part that gets students really messed up. When do I change gloves? I'm going to tell you that there is no checkpoint on when you change gloves. As we go through this, I'm going to explain to you the checkpoints that they are grading with gloves. I'm going to tell you when to change your gloves for optimal infection control practice. But don't get too terribly hung up on when, you know, what do I do here? That's where most students get a little tied up. So this is our care plan. And man, this is a long care plan. It tells us a resident with dentures is sitting at an overbed table with their dentures and a denture cup. Good morning. The resident's denture needs to be brushed with toothpaste and the resident needs mouth care. The denture is stored in a denture cup after cleaning. The resident is not able to provide own mouth or denture care. So there's a whole lot to this care plan. So let's take it bit by bit. First part says the resident with dentures is sitting at an overbed table with their dentures and a denture cup. Just like this. This is how your patient is going to start the skill. Now, if you go back a page, you can see that this is a live patient skill, and I'm assuming most of you guys don't have dentures. So how are we going to do this as a live patient skill when you don't have dentures? The way that this is going to work is all about this care plan. It does not tell you to take the dentures out. It tells you they're sitting at a table and the dentures are already in a cup. You're not taking anything out of their mouth. It also tells you at the end of the skill, you're going to store the dentures in the cup. You're not putting them back in. So that means that we can have a live student be the patient for this skill, for the mouth care part of this skill, because you're not taking dentures out or putting them in, and that's important. CNAs do not take dentures out, and you do not put dentures in. The patient has to be able to do that on their own. If they cannot, in a clinical setting, we don't give them their dentures. We puree their food. We chop it up really fine, and they don't use dentures. There's a very good reason for that. If you try to take dentures out of somebody's mouth, dentures are held in usually with suction or denture paste. In a lot of cases now, with the newer dentures, you have little posts that are actually implanted that they clip onto. So there's a lot of different ways that dentures, but they're held in. So that means that we have to use a little bit of force to get them broken free to remove them. Make sense? Now, if I'm doing that on myself, if I'm taking my own dentures out, I'm going to put my fingers all the way in the back, and especially on the bottom, I'm going to pop that denture up and out, but my angle is such that I'm not putting a lot of pressure on that lower jaw. Okay? Now, if I'm going to do that to somebody else, that changes. Because when I put my fingers in somebody else's mouth, in order to get leverage, these knuckles right here have to press down while the fingertips pop up. And that downward pressure can dislocate the jaw. So we don't take dentures out, not our job. We can actually dislocate a jaw taking dentures out. So patient has to do that on their own. What about putting dentures in? Well, when somebody puts dentures into their mouth, they unconsciously bite down to seat those dentures to get them up or down on the gums where they're supposed to go. Well, if your fingers are in somebody's mouth and they bite down, what's going to happen? Yeah, and they don't mean to. This is a reflex. They don't mean to bite you, but your fingers should not be in their mouth while they're trying to seat their dentures. So because of the risk to the patient and the risk to you, we don't take dentures out and we don't put them in. Good? Make sense? Yay. I'm all about that. All right. It tells us the resident's denture needs to be brushed with toothpaste and the resident needs mouth care. Now, we're going to talk about that toothpaste thing in just a minute. So we're going to set that aside for just a second. I'm coming back to that. But it also says the resident needs mouth care, and that is absolutely true. When a patient has dentures, we can't ignore the mouth those dentures came out of because that denture paste is holding food particles against their gums. And you can end up with some really serious problems. And I'll tell you the worst one I ever saw. This was absolutely horrible. This happened in an assisted living facility. Long-term patient with dementia living in an assisted living facility, and she had dentures. Well, nobody was cleaning the mouth. And what had happened, because she had dementia, she was nonverbal. What had happened was there was food that was pocketed up in her cheek area, and that food degraded and decayed and actually ate into her gums, and it ate away her gum. Well, on the other side of your gum is your sinus cavity. So it actually ate up into her sinus cavity, this decay, because nobody was doing mouth care on her and nobody was checking. She's got dementia. She can't let us know there's a problem. Well, nobody realized that there was an issue until she got a sore on the outside, because now it's eating its way out. So that decay started to get a sore on the outside, and they thought it was just like a pimple. How many 90-year-olds do you know that are getting acne, right? So nobody reported this. Nobody did anything about this. Well, that abscess, and it's now an abscess, actually went through her sinus cavity and into her brain, and that is what ultimately killed her. Yeah. In the meantime, before she died, she ended up with losing half of the skin on her face. I mean, she literally looked like Freddy Krueger. What? I don't even have words for this. Okay. And I actually took care of this woman. When I was in hospice, she was my hospice patient. And this was just sickening to me because it could have been prevented. She did not need to go through this. This is neglect. This is awful. But what was even worse, what made me super angry about this, is that she was paying $6,000 a month to be neglected out of her pocket, out of her bank account, because assisted living facility is not covered by insurance. You have to sell your house. That money goes into an account to pay for your care. That's horrible. We should not be treating people like that. And when I went to the staff and I said, isn't anybody doing mouth care? Well, she has dentures. Okay, you're cleaning the dentures, good. But what about the mouth those dentures came out of? Oh, well, I didn't know I had to do that. Okay, well, Exhibit A, this is why we have to do that. Now, how do you think the family felt? If I came to you and told you that grandma, your grandma, had that happen, how would you feel? What emotion would you have?
So much emotions. Like we paid like $6,000 a month for you to take care of us, but you didn't.
Yeah, you didn't do your job.
Yeah.
And my grandma has to suffer. I would be angry.
Yeah, exactly.
I would be angry. What we do and don't do really matters. So when it comes to denture care, don't neglect the mouth those dentures came out of. Good? Okay, it says the denture is stored in a denture cup after cleaning and the resident is not able to provide their own mouth or denture care. So we're going to do a good job. Now, for this skill, we know all of the principles that we need to know. There's nothing new to learn here. We know to read the care plan. We know to do the opening. We know to evaluate if we need gloves. And yes, we do. We need 2 sets for this skill. We know to use a barrier to keep our table clean and our supplies clean. We know linen rules. We know how to clean the basin, and we know how to do the closing. There's nothing here that we have to learn other than skill-specific steps. So what do I need to know about this skill specifically? And that's what we're going to focus on here. So CNAs clean both dentures and the mouth they came out of. But there's 3 different types of dentures on the screen, and I want to talk about that for a second. So when I say the word denture, most of you think of this. This is a denture. Now, this is a top plate, and I know it's a top plate because it has a palate. This goes against the roof of the mouth, okay? So this is a top plate. A bottom plate looks more like this. It has a cutout for the tongue. So that's how you know which is a top and which is a bottom. Okay. But this is a full plate. Now, a full plate means that we're going to replace all of the teeth, not just some. Right. So this is their false teeth, their fake teeth, their replacement teeth. So we have pulled all of the teeth from the top to replace this. So it would go in like this. Okay. But if the patient has some healthy teeth left, we don't want to pull healthy teeth. We want to leave healthy teeth. And then the patient would have what's called a partial. Now, a partial replaces some teeth that are pulled, but it has gaps for teeth that need to be, or that we need to work around. Okay. So we're replacing some teeth that the patient no longer has. And then we have gaps to fit around the teeth the patient retains. Now, most partials have some sort of a clip or a ring or a fastener of some kind to hold them in place. So there's full plates, there's partials, and then on the screen you see one that just has like 1 or 2 teeth that are replaced with some rings. Those are called bridges. Now, most bridges now are permanent. They just implant them, they affix them. So we're kind of changing technology a little bit. You may see some patients that have some bridges implanted, and you won't have to do anything with those other than brush them like regular teeth. But some of your older patients will have older technology, which is a removable bridge, which just replaces a few teeth, and it has some rings to attach to the teeth around them. Okay. All of these are going to be cleaned the same way, but it's important that you understand that there are different types of dentures. Now, I don't have any up here because we've sold them all. We had a big order come in over the weekend. But if you get our practice kit, we actually have practice dentures for you to work with. And it has a groove, just like a regular denture. It has replacement teeth. You would brush this just like you would brush an actual denture. It's just a simulator. They won't actually fit in your mouth, so please don't put them there. Okay. My mom actually makes these for me. We are a true family business. Put mom to work. All right. So if you order the practice kit, you get practice dentures to work with. So there are 2 ways to clean dentures. The first way is using toothpaste and a brush, just like you would brush your teeth. That's what we're going to use for the state exam because our care plan specifically tells us toothpaste. But in most settings, we're going to use fizzy tablets instead of toothpaste. That means we're going to put them in a cup with cool, clean water, put our fizzy tablets in, and let them go to work. Now, the fizzy tablets are actually better than toothpaste in a lot of cases. Toothpaste is abrasive. It's going to scratch the surface of the dentures, which decreases the longevity of them. So it allows areas for bacteria to kind of hide out. We don't like that. So most people that make dentures will tell you to use fizzy tablets. Those fizzy tablets actually break down the food particles and the denture paste without damaging the denture material. So which method would we use? Whichever one is on our care plan. If we're going to use toothpaste in a brush, we generally use this kind of a brush. This is a denture brush. It has a bigger section and a smaller section. The bigger section looks like a toothbrush, and we're going to use it on the teeth. The smaller section is designed to fit in the groove of the dentures, the part that goes over the gums. This is too big to fit in that groove. It's not going to clean, to get to the bottom and clean it as effectively as this. It's got a tapered end on it, so it fits in that groove very, very nicely. So we use this for the groove. We use this for the teeth. We're going to do this just like we do mouth care. You wet the toothbrush first, you put your toothpaste on, and then you put it in a basin until you're ready to use it. Now, the basin is going to be more important in denture care than it was in mouth care. Because in mouth care, you're working on your table and you've got your barrier on your table. So if you put the toothbrush down on the barrier, it's not a big deal. But with denture care, we're using this on the dentures, and we don't clean the dentures at the table. Where do you think we clean dentures at? At the sink. So if we don't put this in our basin, we dump it in water, put toothpaste on it. If we don't put it in our basin, when we get over to the sink, we have to have somewhere to set this down. And we don't want to set it on the side of the sink. And that's because the side of the sink is not clean and we don't want to contaminate our denture brush. So we wet this, put toothpaste on both sides, and put it in our basin. All this basin is going to do is hold the brush. That's its whole job, hold the brush. Okay. Now I am going to tell you it can have a second job. For the test, we only have to clean one plate. So it'll either be an upper or a lower, but you're only cleaning one. They make it super easy for us on the test. One plate. But usually your patient has two. So what do you do with the clean one while you're cleaning the second one? We don't want to put it in the dirty denture cup that hasn't been cleaned yet. Your basin can hold the clean denture while you're cleaning the second denture and cleaning the cup out. Okay, so it can have a second job as well. All right, dentures have to be either in the cup or your hand or the basin. Those are the only places the denture can be. You can't set it down in the sink. You can't put it on the side of the sink. Dentures have to be protected. They're incredibly expensive. Speaking of protection, we're going to put a washcloth in the bottom of the sink to line that sink. That way, if we accidentally drop the dentures, and we can because toothpaste is slippery, water is slippery, gloves can be slippery. So we got a lot of slippery things going on here, and our dentures might actually fall. So if we put a washcloth in the bottom of the sink, it can help provide a softer surface for those dentures to land on should they fall. You also want to keep your hand kind of low in the sink and not like really high, because if the dentures fall, you don't want them to go too terribly far. Now, if you can get that washcloth over the drain, the water will pool up in the sink a little bit, and that can actually help prevent crashing onto the bottom. So that washcloth can provide a softer surface, but I put it over the drain to give me a little pool of water to help provide that little bit of extra protection. Remember that your denture brush cannot touch the sink. That is a graded checkpoint. We're going to use cool water when we're cleaning dentures, not hot water. There's an old saying, heat coagulates proteins. And what that means is, for you guys, if you use hot water, it makes the proteins stickier and harder to remove. Well, the gummy paste, that denture paste, that has a lot of protein. The food particles that are in the denture paste has a lot of protein. Your saliva that's coating the dentures has a lot of protein. We don't want to make them harder to remove. So cool water is best. Okay. Use paper towel to turn that cold water on. This is a graded checkpoint, cool or cold water. We're going to brush everything, whatever you see, top, the bottom, the front, the back, the groove, the teeth, all surfaces of that denture. You're not graded on how long that takes. So move along. Remember, you only have 13 minutes to do this skill. So don't spend 10 of it doing the dentures. Move along. Rinse all surfaces. Remember that we have to have gloves on to touch dentures. You can touch the denture cup without gloves. You can touch the basin without gloves. You can touch the denture brush without gloves, but we have to have gloves on to touch the dentures. That's our graded checkpoint, okay? Once you've done denture care, then you don't want to touch this without gloves. Okay. So we're going to keep the dentures in our hand over the sink. We don't want to set them down in the sink. Graded checkpoint. We're going to rinse the denture cup out and fill it up with cool, clean water. That's a graded checkpoint. And then we're going to store the denture cup on a paper towel on the bedside table. I don't have a paper towel with me, but on a paper towel on the bedside table at the end of the skill. It's there for your patient to use whenever they want to use it. Now, I am going to time out here real quick and talk about something on the written test that doesn't have anything to do with this. Because for the exam, your denture cups are not going to be labeled. You're only there for 10 minutes, you know. It won't have a name on them. In a clinical setting, your denture cups have to be labeled, have to, and not labeled on the lid. The actual cup has to be labeled. And that's because most places have roommates, and we don't want to mix up Mary's and Helen's dentures. So we label the cup. Now that could be on the written test.
What would we add to it? Like his or her name and the dentures.
It'll say, yeah, Mary and then room 205B.
Okay.
Okay. Good. Makes sense. All right. We're going to wring that washcloth out that was in the bottom of the sink and dispose of that. We're going to carry our basin and denture brush back over to the table. And I've done all of this with my denture gloves on. Okay. So I took my cup with my paper towel over to the side table, set it down, wring my washcloth out, put it in dirty linen, carried this over to the table and set it down. Now I'm done with dentures. I'm going to take this out, put it to the side because I don't need it anymore. I'm done with dentures. This is when I would take off my denture gloves. Okay. So I need 2 sets of dentures. I need 1 set or 2 sets of gloves. I need 1 set for the dentures and I need 1 set for the mouth. Because if I'm going to brush your teeth, you probably want clean gloves for me to do that. That is why this skill requires 2 sets of gloves. Okay, so when we're all done with the denture part, we can take those denture gloves off, and then we're going to get ready for mouth care. Now, I don't have gloves on yet. I'm going to get my toothette. Toothette is what we generally use when we're cleaning the mouth of somebody that has dentures. It's soft, it's spongy, it looks like a lollipop, doesn't taste like one, but it's solid surface, and that's kind of important because remember there's denture paste and food particles left over. If I try to go in with a brush, that denture paste is going to get all bound up in that brush, and after a few seconds, it's not going to be effective. It's going to be all gunked up. So we use a solid surface when we're cleaning what's inside the mouth because I can swipe and turn, swipe and turn, swipe and turn, and it gives me 4 independent surfaces to work with. Make sense? So this is a toothette, or also called an oral swab, because remember, everything in healthcare has 2 names. All right, so we're going to wet it like we do a toothbrush. We're going to put toothpaste on it like we do a toothbrush, and then I'm going to set it in the basin like I do a toothbrush to put the towel over the patient. Now that I'm all set up, ready to go, the first thing my glove should touch is the patient. So this is when I would put my gloves on. Then I'm going to brush whatever the patient's got. Top, bottom, front, back, tongue, just brush what they've got. This is your whole checkpoint for the mouth care portion. This is it. It says provide mouth care.
Especially when we do the dentures, we use this to clean the mouth when we especially clean the dentures and not the mouth care separately, right?
So yeah, denture care is dentures and mouth care.
Yeah. Okay.
We have to do both.
So like when we do the mouth care, we don't use this like brush, like
No, what?
separately.
Yeah, when we do mouth care, it's mouth care with teeth.
Yeah.
So we're going to use a toothbrush.
Okay.
When we do denture care, their teeth are in a cup. So it's the toothette because we're working with gums. I know it looks like he has teeth, but for the test, we're going to ignore those and pretend they're gums. Okay? So this is your whole checkpoint. It says provide mouth care, cleaning upper and lower gums using moistened foam tip applicator or toothbrush with toothpaste. So for the test, if you wanted to use toothbrush and toothpaste, you could, but it's not as effective in a clinical setting. It just doesn't work as well. The foam tip applicator or toothette is much, much more effective. Okay, then you got to let them rinse and spit just like we did with mouth care. And this patient is sitting up in a chair. Remember, our care plan told us they're sitting in a chair. So this is actually a little bit easier because they can lean forward. This is, even though there's an extra step here, it's actually an easier skill than mouth care, I think. Make sure their face is dry, just like we did with mouth care. And then we're going to clean the basin like we clean all basins. Rinse it, dry it, store it. Put your dirty linen in the dirty linen hamper, the towel that was over them. And then take your gloves off and do your closing. Okay. So this isn't a hard skill, but it is a long skill. I will tell you, I don't think it's a hard skill, but I will tell you that students have told me this is the most challenging skill for them because it does have two parts to it. We clean the dentures and then we clean the mouth the dentures came out of. It's kind of like two skills in one. So this does tend to be a bit challenging for students. I think that once you practice it once or twice, you'll kind of get over that and it will feel a little bit easier. So now that we know all of our steps, let's see how we're going to check them off. Guys, this is your checklist for denture care. Look how long that is. Look how many steps you're being graded on. So it kind of looks a bit intimidating, doesn't it? Let's see if we can make it a little bit easier, okay? So we know we're going to use those principles to check off those steps. So we're going to follow our care plan and we're going to do our opening. Look how many check marks we're going to get for our opening. We're going to wear gloves. Look how many check marks we're going to get for gloves. We're going to use a barrier. Whoop, no, we're not going on break. We are going to use linen rolls and basin cleaning. So when you look at this checklist, there's a lot of steps, but we've already got half of them checked off. Now, our skill-specific steps are going to be quite a few here, but then we're going to add in our closing as well. So even though this looks like a whole lot, it's not as many as you think when you kind of realize you already know half of everything on this checklist. You've heard me say it over and over and over, and I'm not done yet. You're going to hear it again on Wednesday and again on Monday. So these are all things that you should be able to roll your eyes at by now. Okay. Remember, this care plan is for this patient, nobody else. Every patient's going to be a little bit different. We're going to go by our care plan for that patient. So we're going to go ahead and watch the video for this one. And Jake will put that up.
Good afternoon, Mr. Jones. How are you?
I'm well. How are you?
Wonderful. My name is Patty. I'm your CNA today, and I would like to help take care of your dentures and perform mouth care. Is that okay?
Yes.
I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. I'm going to take your dentures to the sink to clean them.
Okay.
I'll bring the denture cup to the sink on the paper towel. We're going to set it on the side of the sink and open it, placing the lid beside it, and then wash my hands. After washing my hands, I'll get my supplies. We're going to start with a barrier. This is going to provide a clean place to put our clean supplies. So we'll spread the barrier out on the table with the absorbent side facing up. And for this skill, I'll need a towel and a washcloth, being careful not to let the supplies touch my uniform. I'm just going to go gather the rest of your supplies. I need a toothette, a denture brush, and toothpaste, along with an emesis basin and a cup of water. We'll set these on the overbed table. And I need 2 sets of gloves. Okay, I'm going to get the denture brush ready. We're going to wet it and apply just a little bit of toothpaste on both sides. Set it in the emesis basin right now. I'm going to take the washcloth, a set of gloves, and the emesis basin holding the denture brush to the sink. Mr. Jones, I'll be right back. I'm ready to clean the dentures, so I'll set the prepared denture brush in the emesis basin on the side of the sink. I'm going to place the washcloth in the bottom of the sink over the drain and put my gloves on. I'll take a paper towel and turn cold water only on because we only wash dentures with cold water, and we're going to throw that paper towel away. Now I can clean the dentures. I'm going to take them out of the denture cup and rinse them off, making sure that I hold them over the sink at all times. I'll take the denture brush, and the small end of the denture brush is going to clean the groove part of the dentures. So we're going to clean that whole groove, all areas, and the palate. Then we'll turn the dentures over, being careful to hold them securely, and use the other side of the denture brush to clean the teeth part of the dentures. We want to make sure that we cover all surfaces. Making sure that we hold it securely. And then we can rinse the denture brush and put it back in the emesis basin for later use. We're going to rinse the dentures off, removing all of the toothpaste. We'll take the denture cup, dispose of the water, rinse it out, and fill it with cool, clean water, placing the dentures inside, cover it with a lid. We can throw this away and get a clean paper towel to place underneath it. I can turn the faucet off, and we're going to go put this on the patient's bedside table. I'll place this denture cup on your bedside table over here for use later. Now I can remove the washcloth and place it in dirty linen. Now I'll bring the emesis basin holding the denture brush over to the overbed table and take the denture brush out and set it aside. Now I can remove my gloves. I'll throw these gloves away. Mr. Jones, I'd like to place this towel over your chest while I perform the mouth care portion of this skill. Is that okay?
Yes.
I'll get the toothette ready. We're going to get it wet. Put a little bit of toothpaste on it. And then hold it in the emesis basin while I put my gloves on. Okay, Mr. Jones, I'm going to brush all areas of your mouth, the top, the bottom, the front, the back. So I need you to open up wide for me, please. I'm going to start in the back, on the top, both sides, and then the bottom in the back, the front, and can you bring your teeth together? Thank you. Okay, thank you very much, and we'll rinse. Okay, pour the rest of the water in there. And just make sure that your mouth is nice and dry. Okay, I'm going to place this in dirty linen, clean my basin, and then clean my work environment. I'll be right back. We'll take the basin to the sink and dispose of the contents into the sink. We'll then rinse the basin and set the basin down in the sink. We'll use a paper towel to pick it up, a paper towel to dry the inside, a paper towel to dry the outside, and then one more for the drawer. On the way to the drawer, we'll pick up the denture brush and the toothpaste, placing them in the emesis basin for storage. The supplies away, we'll use a paper towel to open the drawer. We're going to put the basin, toothpaste, and denture brush in the drawer and then close it with the paper towels, and we can then throw the paper towels away. And now I'll dispose of all of my disposables. The cup, the wrapper, and the toothette, along with the barrier. These will go in trash. Now I can remove my gloves. We'll throw the gloves away. Thank you very much, Mr. Jones. Is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes.
Would you like a magazine before I go?
No, thank you.
Your environment is clean, your bed is in a low position, and you're safe. Let me give you your call light.
Okay.
Here's your call light. If you should need anything at all, just press that red button and we'll be happy to come back and help. I'm going to go open your curtain and wash my hands. After washing my hands, I'll review the care plan, make any corrections, and then tell the evaluator my skill is done.
Any questions on that one? Okay. The practice kit does have a denture simulator in it, just so that you know for future. You've got them here if you're going to be practicing in the classroom. But if you're not practicing here, you need to be practicing somewhere. And that means you need the supplies to be able to practice. So the next skill that we're going to be going over is ambulate with a gait belt, and the gait belt is also in the practice kit. So that will be important for you as well. So page 66, we'll introduce ambulate with a gait belt. So we're going to get through this one before we go on break. So break might be a little bit late today. I want to get through ambulate with a gait belt because partial bed bath is super long. It's the longest skill that we have. Takes me a little bit of time to teach you. So let's get this one done before we go on break. If you look at the principles involved, you'll see there aren't very many. So there's skill rules, there's the opening, glove rules. Those are kind of our normal ones. But we do have one that we're going to have to learn. I'll talk to you about that in a minute. And then there's the closing as well. If you look at the bottom of the screen, you'll see that somebody with your level of experience should be able to do this skill in 5 minutes or less. It's a quick skill. It's a live patient skill. You might be the patient for this. And at the beginning of the skill, you will be sitting in a chair to start the skill. So page 67 has our care plan at the top of the page, step-by-step instructions, and supplies are at the bottom of the screen. Here's our care plan. Ambulate the resident at least 10 steps. Use a gait belt or transfer belt. Patient will be sitting in a chair at the side of the bed with their shoes on. So I'm going to stop there for a second. For the test, your patient will already be wearing shoes. Do you remember I told you that that is the one thing that's required for a dress code for testing is closed-toed shoes. No sandals, no flip-flops, no high heels, closed-toed shoes. So they don't care what else you wear. They need you to have shoes on for this specific skill. This is the one skill that requires something of you as far as apparel. So because our care plan says that the patient is sitting in a chair at the side of the bed with shoes on, you're not going to have to put shoes on the patient. So if you go back a page and look at the supplies, you'll see shoes are listed as a supply, but our care plan tells us the shoes are already on, so we're not going to have to put them on. Please be aware that they shouldn't. They're not supposed to. But sometimes evaluators can kind of go off script. They're not supposed to. They can get in trouble for it. But sometimes the evaluators will have the patient take their shoes off and put them right beside. What they're trying to see is, do you understand how important shoes are when you're ambulating somebody? So if the patient's shoes are not on and the care plan says that they are, but your eyes tell you that they're not, then you need to bring that up to the evaluator.
Oh, we're not supposed to wear that shoe back on. And
You need to tell her the care plan says the shoes are already on. And the evaluator may tell you, well, you need to take care of that, or just follow their instructions at that point. Okay. But I want you to say something, because that tells them that you understand the importance of the care plan. Does that make sense? But it also tells them that you caught them, and they're less likely to continue doing it. Okay. Remember, they have to play by the rules too. But unfortunately, not everybody is a rule follower. All right. So it tells us patient is able to walk, but needs assistance to stand. You are going to be you in the test. You are going to walk like you walk. So I don't want you to turn into a 90-year-old invalid and, do something like this. Okay. If you're the patient for this, you're going to walk like you walk. Okay. But it does say that you need some assistance to stand. So that's how we're going to approach this. We're going to use a gait belt to help our patients stand. Now, we're going to talk a little bit about energy conservation and the use of the gait belt coming up here. We already know these 4 principles, but we do need to learn this one. And this is called shoe rules. This is our very last principle that we need to learn. Everything else we know. But the notes for what I'm about to tell you are on page 63. This is where our notes are. Have you guys ever seen a 2-year-old? 2-year-olds are great. 2, 3, it's my favorite age. I love 2 and 3-year-olds. They're amazing creatures. But man, do they have energy. Off the charts. 2 and 3-year-olds will jump up and down for no reason. They don't need a reason. They just got excess energy. They will bounce. When was the last time you jumped up and down for no reason? Oh, well, good. For no reason. Very good. You've got energy. The problem is that most people don't. Our energy levels actually decline. They, generally speaking, max out at somewhere around 2 or 3. That is the most energy you will ever have in your entire life. And I'll prove it to you. Let's go out to 12. Okay, 12-year-olds. Still tons of energy. They can run circles around me. They're still great creatures. But you put that 12-year-old in charge of that 2-year-old for one afternoon, who wins? 2-year-old. 12-year-old's like, Mom, can you please have them sit down? You know, give me a break. We have declined in energy levels just between 2 and 12. Let's go out to 22. Now, 22-year-olds still have tons of energy. You guys can shop till you drop and go out at night looking fabulous, right? Still tons of energy, but you do not have the same energy you had when you were 12. Go out to 42. Now, 42-year-olds are shopping till they drop, but that's at like 3, and we're not going out tonight. Okay? Go out to 62. Now, at 62, we're putting up our feet for 10 minutes before we make dinner because, man, there's just not enough energy to get everything done. We're thinking about retirement because just our daily activities are kind of zapping us, and to try to throw work in there as well, it's just too much. We don't have the energy levels to maintain that amount of energy expenditure. What do you think our energy levels are going to be like at 82? Super low. Now, the problem is, have you ever tried to explain to a 2-year-old why you don't have the energy they do? Do they ever get it? No, they can't because they've never experienced it. They have no frame of reference, right? You can't get them to understand something they've never experienced. Does that make sense? All right. Well, if you look on this energy graph here, right? Tons of energy, a little bit less, and it goes down as we age. So our patients are here on this amount of energy. Beep, that much. You guys are up here with this amount of energy. They're trying to tell you, I don't have the energy for that. That's like you trying to tell this person, you don't have the energy for that. They don't get it, and either will you. You're going to end up saying things like, oh, come on, I'll do all the work. All you have to do is sit there and let me shower you. It still takes energy. You don't understand their frame of reference any more than that 2-year-old understood yours. Does that make sense? It's important that you understand that because when your older patient says, I don't have the energy, they mean it. No amount of badgering from you is going to make them automatically conjure up some energy. It doesn't work like that. So now we have to start thinking about, well, what kind of things take energy? And the answer to that is if you've ever been able to say, I'm too tired to, then that thing takes energy. Have you ever been too tired to talk? Have you ever been too tired to shower? Have you ever been too tired to eat? Have you ever been too tired to work? If you've ever been too tired to, that thing takes energy. These are all things that your patients might say, I don't have the energy for today. So we have to understand that if we only have this much energy to get through our day and we have to do all of these things every single day, that might take up our energy. Does that make sense? Something else that plays into this that you guys probably haven't thought about are your own individual habits. Some of you are morning people. Do I have any morning people like to get up super early? It's quiet. Okay. I've got some morning people here. I am not a morning person. If you get me out of bed before the sun, I'm bringing an attitude with me. Okay? Not a morning person. I am a night person. I come alive around 4 p.m. That's when I get the most energy and the most creative. And that's when I like to do all of my work, right? Is in the afternoons and evenings. That's when I'm at the top of my game. So you morning people, you don't understand that because by 4 p.m., you're like starting to wind down a little bit, right? You don't understand that. Okay. And then there's some people that are true night people. They don't come alive till like 10 o'clock. And they're good overnight, but don't try to get them to do anything at 10 a.m. because they just aren't going to do it. They're just not. So we have to understand that our own circadian rhythms are going to play into this as well. If we have somebody who is an afternoon person and we're trying to get them on the morning shower schedule, do you know what they're going to tell us? Yeah, no, I don't want that. No, leave me alone. No. So we have to understand that your patient's habits and trends and circadian rhythms are going to play into this as well. Does that make sense? We want to try to schedule activities when your patient has the most energy. So if you've got an afternoon patient, then an afternoon shower might be a better fit. Good? Makes sense? Okay. I'm an afternoon person, but I take my showers in the morning because I got to have something to wake me up, right? So for me, a morning shower is a good idea, but that doesn't mean that all afternoon people are going to think the way I do. Have you ever stopped to think about that? People are different. They're different. And if we go at this, if we treat all of our patients like they're exactly the same as us, we're going to end up with some friction here. Okay, good? Make sense? All right. So let's talk diabetes because this is going to play into our conversation. I'm going to give you a 5th grade version of diabetes. This is not overly complex. It is not technical. It is a simplified view. So those of you who have more knowledge about diabetes understand that I am oversimplifying this on purpose. This is a very big topic. Okay. So every cell in your body needs energy, and the energy that it uses usually comes in the form of sugar. So we get sugar through foods that we eat, particularly carbohydrates. Carbohydrates break down into sugar. The sugar goes into your bloodstream, and your bloodstream triggers the release of insulin. Now, insulin is a key. That's all it is. It's a key. So your cells need sugar to function, but the cells actually are locked. They have a door on them that's locked. And that door will stay locked unless we have a key to open it. So when we eat carbs and they break down into sugar, your body tells the pancreas we need some keys to unlock the cells. So in a healthy, functioning pancreas, the pancreas would produce some keys. The keys go into the bloodstream. Now we've got sugar and we've got keys. The keys unlock the door and everybody is happy. Sugar enters the cells. Our cells are well fed and functioning optimally. This is ideal. This is what we want to see. Now, the problem is with diabetes is that the pancreas either doesn't produce keys, it just offline, not working, or it produces the wrong kind of keys. It's giving us car keys. We need house keys, right? Your car key does not open your house. Never will. So we've got to have the right keys. So that's where diabetes comes in. Because the sugar can't go into the cell, it stays in the bloodstream. Our blood sugar rises. So we've got a lot of sugar in the bloodstream. The problem is those cells are starving. The sugar isn't getting into the cells. So the cells start yelling at the brain, we're starving. I'm dying. And they're literally dying, literally, not figuratively. This is literal. They are dying. So they send out this SOS to the brain. I'm dying. I see the sugar. Help me. So the brain hears the distress call and says, oh, you need sugar. And what's the best source of sugar? Candy bars, cakes, cookies, all the good stuff, right? So it triggers a craving. So your diabetic patients start craving sweets. And that craving is super strong on purpose because the cells are starving. Well, we know it's not going to help because they eat that pastry or cookie or M&Ms or cake or whatever. It goes into the bloodstream. We have more sugar in the bloodstream, but it's still not getting into the cells. So the cells keep screaming. The brain keeps triggering cravings, but none of that is helping the actual problem. Does that make sense? So this is a 5th grade, seriously watered down version of diabetes. Now we've got to talk about what's happening in the bloodstream. So we know our cells are dying. We know they're starving. But what does that mean for our bloodstream? So we've got all of this sugar that's in the bloodstream that can't get into the cells. And we just keep dumping more in because of these cravings. We got lots of blood sugar in there. Well, sugar is a crystal. And if you've ever looked at crystals under a microscope, they kind of look like this. Right? They're sharp, they're jagged, they're crystals. Well, this is what's in the bloodstream. They're crystals, they're sugar. And these crystals are going to coat the inside of the arteries, and it makes the arteries stiff. So now your arteries can't expand and contract around those waves of blood. Remember those waves of blood we talked about? Right? The hose can't get bigger, it can't get smaller. Hose is kind of stuck because it's all coated with crystals on the inside and they're stiff. So that's not good for our blood pressure. Make sense? Okay, but because they're crystals, and this is what's coating the inside of the arteries, it's going to catch all the stuff floating by. So it's going to, hi, you're in the right place. You looked. Oh, sorry, that was my fault. So we've got these crystals that are collecting all the stuff that's floating by, like cholesterol. Now, cholesterol in your arteries actually looks like pizza cheese. I mean, next time you go get pizza and you grab that slice, and that's kind of what cholesterol looks like. So it's going to get all bound up in here. It's also going to shred cells as they go by. So we're going to lose some of our immune cells, right? They're going to get shredded. What does that tell you about the immune system? Yeah, it's going to be decreased. They're going to be more at risk. It's also going to catch up the proteins that we use in healing. So what does that tell you about our healing abilities? We're going to be slow. So this is not good news for our diabetics. We've got a lot of really serious problems going on inside the arteries. And this is what ends up happening. So when we are born, our arteries look like this. I haven't had arteries like this in like forever, right? They're wide open, they're accommodating. These are really good, nice, clean arteries. But as we age, they don't stay like that. They start to narrow a little bit, and then we get a little bit of plaque buildup, right? So we've got a little bit of gunk going on. But this is narrower than this, which means that there's more pressure on the inside. It's a smaller hose. So what is our blood pressure starting to do? Rise, yeah. So if we don't do anything about this, if we just keep going the way that we're going, we eventually end up with this. Now, this is a buildup of cholesterol and cells and crystals and things, and we don't have a whole lot of good area for blood flow there. This is going to affect our healing. It's going to affect the ability to get blood to muscles when we need to move. So we're going to get tired easier. We're not going to get the oxygen to areas that we really need it. Like our whole body is starting to get affected here. And if we don't pay attention, if we keep going, we end up with arteries that look like this. Now, this artery is a diabetic artery, and it's interfering with blood being able to flow through. So blood that slows down or stops clots. And that's what you see here. So our patients with diabetes, end-stage diabetes, what are they at risk for? Yeah, blood clots leading to strokes and heart attacks. That's correct. That's why these what we call comorbidities can really affect our patients with diabetes. Make sense? Not good news, right? Not good news for anybody. So this is why we try to identify people who are at risk for diabetes and intervene early before we get to that point. So do you guys kind of understand a little bit about diabetes and how it works and why it's dangerous and all the things that can happen to our patients if they have diabetes? Okay. This effect, this crystal formation, is going to be most prevalent in 2 places in the body. And this all has to do with gravity, because gravity pulls heavy things down. And sugar molecules or crystals are heavy, so they're going to get pulled down. The lowest point of my upper body are my hands. What's the lowest point of my lower body? My feet. Hand care, foot care. This is why we do them. Is because if our patient has blood sugar anomalies, we're going to see the effects of that in the hands and the feet first. Make sense? Blood vessels are smaller there, and they get gunked up because of gravity. Good?
My dad has some issues going on in his foot because he has diabetes.
Yep, and this is why.
Yeah.
This is why. Any questions on that? But the arteries aren't the only thing that's affected. Nerves are too. So this is a great day to talk about this. Have you ever seen a power line that's coated in ice? What happens is the electricity doesn't always get through, and we end up with brownouts and blackouts because of the ice coating the lines. It interferes with the transmission of electrical signals. Well, it's the same thing in your nerves, right? Your nerves are electrically conducted. So the sugar, instead of ice, it's sugar. These sugar molecules coat the nerves. And you can step on something like a thumbtack. If you stepped on this thumbtack, you would know it's there. You'd hop around on one foot yelling, ow, 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 and you'd pull it out and doctor it up, and you would know it's there. Well, in a diabetic patient, they can step on a thumbtack and not know it's there, because their foot knows it's there. Their foot's like, hey, ow. But that signal can't get to the brain because the nerve that connects the foot to the brain is all coated in sugar. So when we have patients who are diabetic, they are less likely to be able to feel injuries than you are, which means that we can have an injury that goes unnoticed. This is why we have to do foot care. We are there to look for those injuries, but it's also why we have to make sure the patient has shoes on when they're walking. Because in healthcare, we have sharp objects. We have thumbtacks, but we also have needles and lancets and other sharp things that the patient is likely to step on if they're on the floor unnoticed. So your patients should have shoes on when they're walking. If you go into a patient's room and they don't have shoes, who should you tell? The nurse. Slipper socks are not enough. They're not enough. Slipper socks don't protect against sharp injuries. They might help with slips and falls, although they don't do a great job with that. But you know what slipper socks also don't help with? Pathogens. Because if your patient gets out of bed and walks around a clinical environment, patients leak. They leak lots of things. So those floors, and this is no shame on housekeeping. They do a great job, but patients leak. And CNAs and nurses often spill things while they're walking around. So those floors cannot be considered 100% clean. So your patient is walking around on these slipper socks, and then they get back in bed with those slipper socks. And what's getting back in bed with them? Pathogens. Oh, yeah. Like some of the worst pathogens. And then the patient tosses and turns in bed, and those pathogens work up. And if the patient has any incisions or wounds or sores, those pathogens now have a nice, warm, dark, moist place to enter. This is how surgical site infections occur. Good? Make sense? So you're starting to see why non-skid footwear might be important on the test? Okay. So if you go to the test and your patient doesn't have shoes on, the shoes are beside the chair, you're going to say, the care plan says the patient has shoes on. Would you like me to just put them on? But don't walk that patient until they have shoes on. Whether the evaluator does it or you do, I don't care. Don't walk that patient until they have shoes on. And the way that we remember this is if the patient's feet hit the floor, we got to talk about their shoes. Most people in a clinical setting have shoes. They're buried in a closet somewhere. They're shoved under the bed. They could be in a million places, but their shoes are there. If they, don't have shoes, if they're homeless and their shoes fell apart, whatever the case may be, we just let the nurse know, because the nurse has a social worker they can go to, say, hey, this guy needs shoes before, we can't discharge him without shoes. He's got to have shoes. And the social worker can help solve that problem. Good? All right. Slipper socks are not enough to protect against sharp objects and pathogen transfer. And that's a big thing that most of us don't think about. Have you guys ever been a patient in a hospital? When you go to the hospital, they give you a patient gown and a pair of slipper socks, and we love those things. We think they're the coolest things, right? I got slipper socks. You put them on, and then you start walking around, and you probably go to the bathroom, and then you get into the bed with those slipper socks on, and you brought all of those pathogens from that setting into bed with you. And those aren't your pathogens, by the way. You're getting really cozy with your neighbors' uglies. Now, what makes me laugh all the time is right down the road, we have a hospital. We're not going to say the name. And in the lobby of that hospital is a Subway. Hospital food, we all know, is not real high on the I want list, right? So every time I go into that hospital and I walk by, hi, come on in. Yeah, she's in the back. So every time I go in there, there's always a patient in that area. So you have to remember, this patient walked from their bed through the hallways, into the elevator, downstairs, through another hallway, into a public use area in those slipper socks. And then they're going to take that trip all the way back and get into bed with those same slipper socks. Would you get into bed with your shoes on?
No.
Well, getting into the bed with slipper socks is the same thing. We just don't think about it. I think we should be thinking about it. Good? All right. So now we're going to talk about gait belts. So gait belts are going to be put around the patient's waist, not yours, the patient's waist. So I told you we were a testing center for a couple of years, and this I actually got to see happen. And so this student, this applicant who was there to test, clearly had never taken a class, and she was truly challenging and didn't have a clue. And she got the skill, right? So she's using a gait belt. So she picks up the gait belt and she looks at it, and I don't know what was going through her mind. I'm not real sure whether maybe she had worked in a clinical setting or something, but she put the gait belt around herself. And a lot of CNAs will carry their gait belts around their waist, but that's not how they're used. And that's all I can think of, is that this person had seen a healthcare worker with a gait belt around their waist. So she put the gait belt around her waist and she had the patient hold on to the gait belt to stand up. And then somewhere along the line, she realized that that probably isn't right. So she had the patient sit back down. And she took the gait belt off and she put it around the patient at the chest level and pulled the patient up at the chest. And about halfway, the patient's like not stable. So she sits the patient down. And then she stood the patient up without the gait belt and put it around the patient before she started walking them. All of those are wrong. All of those are wrong. The gait belt is not for walking. The gait belt is for lifting. Now, if you've ever had somebody that's sitting in a chair and you're trying to help them, like if you've had an elderly person, you're trying to help them out of the chair, what most of us do is grab the back of the arms. We don't want to do that because we're lifting the top of the body. All of our weight is down here. So when we're lifting the top of the body, we have to put a lot of pressure on the back of the arms to pull them to a standing position. And we actually risk tissue injury. Not a good, we'll bruise them. Not a good strategy. Don't do that. So some people have thought, well, I probably should lift where the weight is, and they'll grab the pants and lift the patient with the pants. Have you ever had a wedgie? Because we're giving them they'll move, and man, they'll move quick. They're moving because you're hurting them, not because you're helping them. So picking somebody up with their pants is not a good strategy, right? We're on the right track, though. We're on the right track. So that's what a gait belt is for. It goes around the patient's waist at their center of gravity. So we're lifting at the heaviest part of the patient, but we're not using their pants or their arms to get them to a standing position. That's what a gait belt is for. So when your patient is sitting, the gait belt goes around their waist. Now I'm going to show you how to put that on in just a minute. We're going to put it around the waist. We're going to get it snug. And when we get it snug, we want to check it with 4 fingers. You just want to put 4 fingers between the belt and the patient. If you can put any more than that, it's too loose. And when you go to lift the patient, that gait belt is going to come up under their breasts, under their arms, or they could just slide right out of it. So we need it snug enough that it's going to stay put. And the way that we check that is to just slide 4 fingers between the belt and the patient. If you can put any more than that there, it's too much, right? The patient will slide out of the belt. If you can't get 4 fingers in between, it's too tight. Your patient can't breathe. Loosen it up. Okay, good. This is a graded checkpoint. Checking that gait belt to make sure that it's the right snugness with 4 fingers. So this is, Jake, I'm going to need a zoom in, please. Thank you. I'm going to take this off so you guys can see. All right, when you put a gait belt around a patient's waist, it does not matter whether the buckle faces this way or the buckle faces this way. Nobody cares. Nobody cares. Whatever way you want to put it on. What matters is the tag is on the inside, like every other article of clothing. So you're going to put this around the patient's waist, making sure it's not twisted over. It's got to be flat. So we put it around the patient's waist, making sure that it's flat. And I'm going to take the free end and we're going to put it through the first guard by the alligator teeth. It doesn't go here. Yep. It doesn't go here. See how I've got the guard and the alligator teeth? It's got to go not on this side of the alligator teeth, between the guard and the alligator teeth. Now, those teeth are all pointing that way, so I'm going to pull it that way to snug it up. Now, remember, I don't want it too loose, so I need to get it snug. I'm going to take 4 fingers and put it between the belt and the patient, and I can fit 4 fingers there. So now I want to take this free end and put it through the second guard to lock it in place. Now, this tail that's hanging down might be in your way. You can just tuck it into the belt to get it out of the way. To remove a gait belt when you're all done with it, we're going to take it out of that second guard and we're going to do the opposite. So instead of pulling the belt like I did when I put it on, I'm going to hold the belt and pull the buckle. To put it on, we pull the belt. To take it off, we hold the belt and pull the buckle. Remove it. When you remove it, you don't want to pull it against the skin. So if I try to pull it off, listen. You guys hear that? That's going to cause a burn against the patient's skin. So you don't want to pull it off. We want to loop it, holding onto the buckle so it doesn't hit our patient's head, or you can reach around the back like this. Either way is fine. Just don't pull it against the skin. Good? Questions? All right. So before we stand a patient, we want to make sure their feet are flat on the floor. Now, for most of you, this isn't a problem. You got long legs. Your feet hit the floor when you're sitting. Now, when I sit in this chair, it looks like my feet are on the floor, but they're actually not. Jake, can you, I'm going to turn to the side. Can you zoom into my feet? Do you guys see that? My feet are not flat on the floor. My heels are up. Do you know why? Because I'm short. That is correct. That is correct. These chairs are made for people that are 5'5" and above. I am not. You know who else isn't? Most of your patients. Yeah, so you can look at, I mean, if you looked at me straight on, it looks like my feet are flat on the floor, but they're not. In order for me to get my feet flat on the floor, I have to scoot forward so that my feet can actually contact that floor. You need to make absolutely sure your patient's feet are flat on the floor before you lift them. Because if my heels are not down, when you lift me forward, I'm going to topple forward because my weight is moving forward and I don't have a good base of support. So for the test, you need to say, are your feet flat on the floor? We need to address this. Good? Make sense? All right. Before we stand our patient up, and that's why you usually see me sitting on the edge of the chair because my feet don't go down. Before we stand our patient up, we're going to count. We want to make them a partner. I don't want to just grab somebody and move them. They may not be expecting it. They're not going to be able to accommodate their body to make sure that it's straight. So we want to count 1, 2, 3 and lift. We always want to make our patient a partner in what we're doing. We don't take over. This is a graded checkpoint. This is a graded checkpoint. Once you get them standing, you probably want to ask, are you dizzy? I want to find out here. So if I get my patient to a standing position and I don't ask, are you dizzy? And we start to walk and I get, what is your exit strategy? What are you going to do? Right? What most people will do is they'll try to rush that patient back to the chair, right? We'll get them back to safety. That is the wrong answer. Is absolutely the wrong. Your patient can't tolerate a slow walk. What makes you think they're going to tolerate a rush? You're going to get halfway there, and where are they going to end up? On the floor. Absolutely. So if your patient has any signs that something is going wrong, if they start to slow down, if they get a little wobbly, if they put a hand to the wall, to their head or their stomach, if they get pale and sweaty, if they look anything like something is wrong, get them sitting on the floor. Pull them next to you. So when you're walking somebody, you should be walking slightly behind and to one side. I'm going to hold that gait belt with an underhand grip, not an overhand. Overhand, if they fall, it'll slip right out. Underhand, if they start to fall, you've got control. Underhand grip. My focus needs to be 100% on that patient, not on my phone, not talking to a staff member down the hall, not on my watch, seeing who just texted me. I should have eyes on the patient. I can't tell you how many times the CNA has said, I don't know what was happening. We're just walking along and then they fell. Okay, patients don't just fall. They tell you they're going to fall. they slow down, they get wobbly, they get pale and sweaty, they put a hand out, up, down. They tell you they're going to fall. If you can bring them to you and slide them down to the floor, or back them up against the wall and help them slide to the floor, either way, get them on the floor. Patients that are sitting on the floor can't fall on the floor. Okay, we're trying to prevent an injury. I can wash off whatever they pick up from the floor. I get soap and water that does that. Soap and water does not wash off a broken hip. Get them sitting. Get a nurse. Good? Make sense? So our focus should be on that patient. We need to be walking slightly behind and to one side with our focus on the patient. But we should also be asking, are you dizzy? If I find out here when I'm at the chair, are you dizzy? And you say yes, you know what I'm going to do? Sit you back down and go get a nurse, because that is above my pay grade. Good? Make sense? We don't want to be walking. So when you stand them up, ask if they're dizzy. When you go to return them to the chair, okay, we've done our walk, we walked. Our care plan tells us at least 10 steps. So that's 5 steps in one direction, 5 steps back. So we walked, we turned around, we came back to the chair. When we go to sit the patient down, they've got to feel that chair behind them. Right now, I can't. I'm too far away from the chair. My backs and my legs aren't hitting the chair. I don't know it's there. You try to sit me down, and if I don't know that chair is there, I'm going to stiffen up because I'm afraid of falling. So I need to back up. I can feel the chair, and then we can sit. Good. Never ask a patient to sit down into a chair they don't know is there, that they can't verify with their own legs. Okay, good. Make sense? That's a graded checkpoint. When you lift a patient, we have to use proper body mechanics. Now, there's 2 ways of doing this. One is what I consider correct, and one is what I consider not correct. Used to be years ago, we trained people to stand toe-to-toe and knee-to-knee when we lifted a patient. That keeps their feet from sliding out from in front of them. I don't like that method for 2 reasons. One, it's very bad body mechanics for you. When you lift body weight toward you, there's a physics principle. Every action has an equal and opposite reaction. So that means when we lift a patient toward us, their body weight has to be accommodated. That means my back has to go back an equal number of pounds of force. So if I'm lifting somebody 150 pounds, it's 150 pounds on my back. How long do you think it's going to be before I lose a disc? Not very long, especially when most of our patients are more than 150 pounds. Make sense? So I don't like that method. I also don't like that method because it actually increases the risk that you and the patient are going to fall. Because if you can't accommodate that backward force, you guys are going to fall. Now, there's a better way, and that's the oblique angle. So if I am sitting in this chair, if you imagine a line across the top of my toes and along each side of the chair, we're going to use that for our oblique angle. And what that means is if I take one of my feet and put it across their feet, okay, across, you can't see it because of the thing, across their feet, what that prevents is their feet can't slide out. So I'm holding their feet steady. This other foot is going to go parallel to the chair. So now I'm standing at the corner of the chair, 1 foot along the side, 1 foot in front. When I stand that patient up, I have much better stability. They're not pulling me or pushing me in the opposite direction. This also helps prevent the patient from falling. So this is a better way of approaching body mechanics. Now, if you want to do toe-to-toe, knee-to-knee, knock yourself out, but, you know, make friends with a local orthopedist because you will need them. All right. We want to bend at the knees, not the waist. We want your legs to do the work, not your back. Remove any obstacles from your path before you stand the patient up and walk. You don't want to leave the patient to have to move something. That's not good practice. So look around your walkway. For the test, it's going to be 10 steps in 10 steps, 5 in one direction, 5 back. So your evaluator will actually give you a destination. Walk to the desk and back, walk to the door and back. They'll give you a destination. Look at your pathway to make sure that there's no obstacles that are in your way that could trip you up. All right. So now that we know all the steps of that, let's talk about of shoe rules. Let's talk about the steps of ambulate with a gait belt itself. So we're going to apply the gait belt while the patient is sitting, and it's going to go around the waist and over clothing. Now, why they have to put over clothing in the checkpoint, that tells me that somewhere along the way, people were putting the gait belt on under clothing. Why? I don't know, but it goes over clothing. Please make sure it's over clothing. We're going to hold the gait belt when we lift the patient, not their arms, not their pants. That's what the gait belt is there to do. It's to help our patient stand up. When you don't want to hold just at the front, sides, or even around the back if you can get it. This is where most of our weight is here. You want to be lifting where most of the weight is, okay? When you're lifting a patient, this is actually in your book. This picture's in your book. When you're lifting a patient, we want the patient to move as a unit. Go back 2 or 3 pages, I think. Yeah, right there. What page is that?
61.
61. Okay. So do you see how she is like this, not standing up, right? Her shoulders are back. This can cause her to fall, but it's also putting a lot of pressure on you. Yeah. So this is likely to injure you. So when you're lifting your patient, you want them to move as a unit. So if you ask them to put their hands on your shoulders, not around your neck, just set your hands on my shoulders. That moves the patient as a unit. It'll help prevent strain on you and falls for them. When we're walking, we're going to walk slightly behind and to one side, holding that gait belt in an underhand grip. Your attention should be 100% on the patient. And as we're walking, we need to be watching our patient for any signs of instability. We can ask them, are you feeling okay? Are you dizzy? Just kind of check in with them. And then we're going to help them sit using that same body mechanics, bending at the knees, not the waist. When we remove the gait belt, we've already talked about that. Don't slide it against their body. And then at the end, we want to make sure that they're seated properly and they look good. So now let's use all of these principles. Raise this up. Talk about body mechanics. Let's use all these principles to check off our checklist. We're going to follow our care plan. We're going to do our opening. We're going to evaluate if we need gloves. Remember, your patient is fully dressed, holding on to all of their own body fluids. Unless you're going to be anywhere near a wound, a rash, a sore, or an incision, you don't need gloves for this. We're going to use those shoe rules that we learned, and we're going to use shoe rules in another skill as well coming up next week. We're going to follow those skill-specific steps and do our closing. And if we do all of that, we will get 100% on this particular skill. This care plan is for this patient, not them. They might walk to the bathroom. They might not walk at all. They may be ad lib, which means they go by themselves, not our problem. This care plan is just for this patient. Remember, every care plan for every patient will be a little bit different. All right, and Jake will show you this video, and then we'll take our break.
Good afternoon, Mr. Jones. My name is Patty, and I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. Do you feel like going for a little walk?
Yes, that'd be lovely.
I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. I'm going to clear the walkway of obstructions. We'll close the privacy curtain and wash my hands. Now that I have clean hands, I'll get the gait belt. Mr. Jones, I see you have non-skid footwear on. Does it fit appropriately?
Yes.
Very good. This gait belt I'm going to put around your waist. It's going to help me lift you to a standing position and provide a little stability as we walk. Is that okay?
Yes.
Okay, I'm just going to slide this around your back. Okay, and lift your arms and relax. We're going to put the free end through the first guard by the alligator teeth and pull it so that it tightens the belt. We want the belt to be snug. We want to only be able to fit 4 fingers between the belt and the patient, and then we'll lock it in place by putting the free end through the second guard. And then we'll place the free end through the top just to hold it in place. Okay, Mr. Jones, your feet are together. In just a few moments, I'm going to have you place your hands on my shoulders, and I'm going to place my hands around your back. And on the count of 3, we're going to stand together. Okay?
Okay.
So I'll put 1 foot in front of your feet to keep them from sliding out, 1 foot beside the chair to keep me at an oblique angle. Go ahead and put your hands up here. And on the count of 3, we're going to stand. 1, 2, 3. Thank you very much. Are you dizzy at all?
No.
Okay. So at your pace, when you're ready, I'm going to have you lead and we're going to walk to the wall. I'll walk slightly behind and to one side, watching the patient. Okay, and go ahead and turn. And then we're going to walk back to the chair. Are you dizzy at all?
No.
Very good. So when you get to the chair, if you can turn around for me and back up so that your knees hit the chair, come my way just a little bit. And on the count of 3, can you feel the chair behind you?
Yes.
You're going to place your hands on my shoulders. Go ahead. I'm going to put 1 foot in front and 1 foot beside. And on the count of 3, we're going to lower. Ready?
Yes.
1, 2, 3. Being careful to bend at the knees and not the back. I'll remove the gait belt by taking it out of the second guard and then removing it from the first guard. We're going to remove it by looping it over the patient, being careful not to let any part hit the patient. And are you comfortable?
Yes.
Could you slide back so that your hips are against the back of the chair? Very good. I'm just going to go put the gait belt away. Are you comfortable, Mr. Jones?
Yes, ma'am.
Is there anything else I can get for you while I'm here?
No, thank you.
Okay, your environment is clean. I'm going to hand you your call light. Here's your call light. If you need anything at all, just press that red button and somebody will be happy to help you. I'm going to open your curtain and wash my hands. After washing my hands, I'll review the care plan, make any corrections that need to be made, and then tell the evaluator my skill is done.
Thank you. All right, any questions on that one? Less than 5 minutes, super easy. I would want that skill. There's a lot to learn about the steps, but once you've got it down, this really becomes a very, very easy skill. We're going to go ahead and take our break, 15 minutes, and then we're going to come back and learn partial bed bath. That's our last skill for today. It does take me a little bit of time to teach you. There is a new principle we have to, or new technique we have to learn for washing. But overall, it follows most of the rules that we already know. It's not hard to learn. It just takes a little bit of time, okay? Then you should have some practice time at the end of class. go ahead and take your break. She is the best. All right, so we're going to move on to partial bed bath. This is not a bad skill, but it is a long skill. So if you look down here, you'll see that we are going to put into practice almost every principle that we have learned. They're all spelled out for us here. So you can tell there's a lot of steps. Okay. At the bottom of the page, you can see this test-specific information. Somebody with your level of experience, which is none, should be able to do this skill within 19 minutes. It's going to be done on a mannequin. This is one of the mannequin skills because we're not going to undress a real person. That mannequin will be in bed. This skill does not require documentation, no charting required. If you go to page 127, up at the top is our care plan, tells us what to do. Here are the step-by-step instructions. They're going to be continued on page 128, just because it is a very, very long skill. And all of our supplies are located at the bottom here. This box right here really kind of helps you understand what we're doing. We're going to wash the patient face to waist, front and back. Face first, no soap. Okay, so this kind of is our shorthand version of this skill. And we get this from that care plan. So here's our care plan. It's extremely detailed. Give the resident a partial bed bath and back rub. So let's time out there. It says partial. That tells us we're not washing the whole body. Don't get fancy on the test and throw in stuff that's not on the care plan. Follow the care plan. But when we're looking at, if it says partial, we need to know, okay, if it's not the whole body, what do you want me to wash here? So partial bed bath care plans are going to be very long and detailed, and that's what we're seeing here. It tells us to wash the resident's face, neck, chest, abdomen, back, one arm and hand, just one. And this is because the test figures if they watch you wash, rinse, and dry one arm, they don't need to see it on the other side. They know you got it. So for the test, you get to pick. They don't care which one, just wash one. They just want to see the technique. Okay? Make sense? It also tells us with soap and water, so it's telling us what to use. Let me talk about that really quick. And I'm going to tell you something I haven't been telling other classes. I'm trying to work this in. If you go to work at a hospital specifically, so I'm going to talk about acute care settings right now. If you go to work at a hospital, we don't use soap and water to wash patients at a hospital any longer. We have wipes, and they're very special wipes. There's 3 different kinds, actually, and it'll tell you, use the purple pack, the green pack, the blue pack. It'll tell you which pack to use. And there's 5 wipes in each pack. They're in a pack warmer. So they're actually going to be warm, thankfully. We don't rinse and we don't dry this off. This is, it provides a bath, right? It cleans the skin, but it actually forms a layer on top of the skin to help prevent bacterial contamination. So if you're working in a long-term care setting, hospice, nursing home, assisted living facilities, home care, we're going to use soap and water, right? But when we're in a setting that has a very high concentration of pathogens, we've moved on to a different technique. We always go by our care plan. Good? Makes sense? All right. And the packs themselves, they have 5 wipes, and they actually tell you on the pack, use wipe 1 for face, use wipe 2 for the torso, use wipe 3. I mean, it tells you exactly how to use the wipes. Okay. And then it tells us to provide a brief back rub with lotion. We're not massage therapists. We're not deep tissuing anything here. It's just for circulation and honestly to make the patient feel good. Yeah, I mean, when you were a little kid and you got sick, mom come along, just kind of rub your back real lightly and it always made you feel better. That's all we're doing here, right? Just to wake up those nerve endings and those capillaries a little bit. So brief back rub with lotion. And then it tells us to dress the resident in a hospital gown. Patient is lying on back in center of bed, can roll as directed, but is too weak to assist with bathing. So we're going to do all of it. Good. Don't put the patient in clothing after the bath. Care plan tells us hospital gown. So all of the what ifs that you have in your head should be answered by our care plan. Remember, this is a care plan just for this patient, not for anybody else. So somebody else, we might be putting clothes on. Somebody else, we might be getting out of bed. You know, it all varies. So we already know all of these principles. We know all of this. We also know washing rules. But there is one part of washing rules that we have not covered yet, and that's what we're going to get to now. So, and washing rules is on, hold on, let me look here. Page 112. So 112 will have some information on this. So to review, remember, basins are no soap zones. We keep the water clean for rinsing. We use a barrier to turn the water on. It should feel warm, not hot, not cold. We're going to check it with our wrist. We're going to ask our patient to check it as well. We know all of this. We know that whatever we wash, we rinse. Whatever we rinse, we dry. We're going to change the water if it gets cold or soapy. And we're going to try hard not to get our surface wet. So if we're working on the table, we're putting a barrier there. If we're working on the bed, we're going to have to somehow protect the sheets while we're washing the patient. We know all this, right? And we also know that if we're going to put lotion on, we warm it up first and then we wipe off the excess. This is all stuff we know. So this is what we're going to learn now. And this is a very special way of cleaning when we're working around very specific body parts. So let me hand these out. This is a play along adventure. Those of you who are at home, if you have a plain washcloth, a square washcloth, go grab it. You're welcome. You're welcome. All right. So this is a plain square washcloth. You guys probably have these in a linen closet at home somewhere, right? Plain square washcloth. We generally fold it in half and then in half again, and we end up with a smaller square. Instead of looking at it as a square, I want you to look at it as a diamond. And when we're talking diamonds, we want the free edges, right? The parts that aren't folded, the free tips at the top of our diamond. Now, we're going to take our dominant hand. So if you're right-handed, use your right hand. If you're left-handed, use your left hand. We're going to take our dominant hand and put that diamond in your dominant hand so the free edges are at the top. Tuck one corner between your thumb and index finger, the other corner between your pinky and ring finger, and now you have a controlled washcloth. So I'm going to use this if I'm going to wash any wet body openings like this: eyes, nose, mouth, genitals, rectal area, wounds, rashes, sores, or incisions. Anywhere where pathogens might come out or anywhere I could introduce pathogens in. Make sense? Mm-hmm. So we, oh, congratulations, Carly. Congratulations. Great job. So the reason that we use this is because it allows me to wipe a wet body opening and then fold that over, which traps contamination underneath and gives me a clean surface to work with. I can wipe another body part, fold that over, and gives me a new cleaning surface. I can wipe something else and fold that over, giving me a new cleaning surface. And I can wipe something with that and I can fold it over and I still have another cleaning surface. So this gives me 5 independent cleaning surfaces without having to change washcloths. This is called the leaves method. Okay, we're going to use this when we're washing any wet body openings, eyes, nose, mouth. And that's what we're doing for this skill, right? We're washing the face to the waist. So there's no wet body openings anywhere other than the face in this particular skill. So we're going to use the Leaves method on the face. So we're going to wipe one eye, fold it, wipe the other eye, fold it, wipe the skin, fold it, and wipe the nose last. I do the nose last because boogers, right? Make sense? Good? All right. So this is just a picture form. So we hold it with the free ends at the top, the two sides tucked in. We wipe something and then we fold that over. We have a clean area to wipe with. We fold that over, clean area to wipe with, fold that over, clean area to wipe with, fold that over, and we can even use the back side as our fifth area if we need it. Yeah, this is going to require gloves. We'll get there in just a minute, but yes, we should use gloves. Now, because it's wet body openings, right? Now, if we're just washing skin that's intact, right? So arms, hands, chest, neck, abdomen, tummy, up the side, the back, right? All of that skin is intact. I don't need this method. I just use a washcloth. Just wash it. But if we're going to wash a wet body opening where stuff can get out or stuff can get in, we need to take an extra step. Make sense? Good? All right. So now that we know all that, let's talk about our skill-specific steps. So we're going to follow our care plan. Now, our care plan is very detailed, tells us exactly what to wash, and that's actually going to be on our checklist, right? Each one of those body parts to make sure that we got them all. So we want to make sure we're following that care plan to get those areas checked off. And the short version of this is face to waist, one arm and hand. We're going to wash the face first, no soap. We generally don't use soap on the face because it stings the eyes and it dries the skin. And the face is, we really don't like our skin on our face to be dry. So generally speaking, water only on the face. Now we can, the care plan tells us we can ask the patient, do you want me to use soap on your face? Personally, I just go straight for water. Good? All right. We're going to use that Leaves method when we're washing the face, changing to a clean area of the washcloth for each eye. And we want to control the washcloth. So we don't want a floppy, wet washcloth just kind of slapping our patient all over. That's why we fold it in half and in half again and hold it in that diamond shape so that we have control over our washcloth. We're going to wring our washcloths out thoroughly, no drippy wet washcloths before we use them, and we apply soap to the washcloth, not the water. Anytime we lift from below, supporting the arm. We know this. Nothing new here. We're going to set the washcloths aside on the barrier. Don't put soapy washcloths back in your basin. Now, time out. Look how many checkpoints we get for this. If you look at the supply list for this, it'll tell you 4 washcloths. It's easier to do this with 5. And you can use 5 if you want. But I'm going to teach you how to do this with the fewest possible supplies. Because if you're the last one testing today, and everybody else before you used up the washcloths, the evaluator has to make sure that if you have partial bed bath, you have a minimum of 4 washcloths to work with. So that may be all that's on their clean supply shelf. Does that make sense? Mm-hmm. I don't know whether you're going to be first or you're going to be last. I have no idea. So I don't know how many supplies are going to be on the shelf for you to be able to pick from. So I've got to be able to show you how to do this with the fewest possible supplies. Now, this is important out in a clinical setting too, because if you've ever worked in healthcare, supplies are at a premium, especially in long-term care. A lot of CNAs will go into a nursing home, start their shift. They pull all of their linens that they're going to need for the entire shift. You go in and there's nothing left. And how are you supposed to take care of your patients if everybody's already raided your supply closet? So you've got to know how to do these skills with the fewest possible supplies because that may be what you're actually dealing with. Okay, so I'm going to show you how to do this with 4 washcloths. 5 is easier, way easier, because you use the washcloth, you set it aside. You use it, you set it aside. You use it, you set it aside. You use it, you set it aside. Easy peasy. But any washcloth that you don't apply soap to, you can put back in the basin. So you can't reuse something that has body fluids on it. So face washcloth, that's got to be, we can't reuse that. That's got to be set to the side. We know that. But the washcloth that you use to wash the torso, one arm and hand, that's got soap on it. We're going to set that aside. The washcloth you rinse with, we didn't put soap on that one. We can put that back in the basin to stay warm, and we can reuse that one. Okay, so I want you to remember that any washcloth that was not used on a wet body opening and did not have soap applied to it, so think any rinsing washcloth, can be reused if you need to. And that's how I'm going to show you to do this. Now, if you have 5 washcloths, take 5 washcloths and use them. You don't have to worry about this. But if you find yourself in a position where I don't have enough, you can do it with 4. A rinsing washcloth can be reused, but we want to keep it warm until we reuse it. So don't just set it aside, let it get cold. Okay, good. I know it's got a little bit of soap from rinsing, but not enough to make that water super soapy. So once we're done with the front, right? So we wash the face, set that aside, wash the torso, one arm and hand, set that aside, rinse the torso, one arm, one hand, put that back in the basin. Once we did that, we're going to pull the patient toward us and turn them on their side, because where should they be after the turn? In the middle of the bed. And then you're going to wash, rinse, and dry the back. There's no special way to do this. Just wash, rinse, and dry the back. Then we're going to take a little bit of lotion in our hands, warm it up, and we're going to do a small back rub. So from the bottom of the back up to the shoulders in little circles, come back down. We'll do that 3 times. Up to the shoulders, come back down, up to the shoulders, and that's the whole back rub. We put lotion on, so we're going to wipe off that excess, and then we want to tie the gown. We're ready to go. Now, let's talk about that gown real quick. You can change the gown anytime in this process. There's nothing here that says when to change. All it says is place clean hospital gown on resident secure gown and back. That's all it says. Doesn't care when you do it. So you can get the patient completely clean, then dress them. Perfectly okay. But that means that you've got to turn them twice. That's a lot of work. So what I do is I take the old gown off, clean, rinse, dry, put the new gown on. Turn them on their side, wash the back, rinse the back, dry the back, tie the gown. Or back rub, tie the gown. So I find it easier to change the gown when I'm doing the front rather than waiting until it's completely done. Because if you wait till it's completely done, you have to turn them twice, and that's just more time. Make sense? Either way is okay, though, according to the checkpoint. All right, so let's see how we're going to use all of these principles to check off our checklist. Long checklist, super long. Remember, you've got 19 minutes to do this. So we're going to follow our care plan. Now, this skill has way more care plan checkpoints than any other. It wants to make sure that you wash the resident's body, that you wash the resident's face, that you wash the resident's neck, arm, hand, and abdomen, and that you wash the resident's back. So there's a lot here on the care plan. We're going to do our opening. We're going to wear gloves because we're around wet body openings. We're going to use a barrier on the table, and we're going to put a towel on the bed. We're going to use a privacy blanket for this. Linen rules are going to apply. Remember, don't hold your linens against your uniform. Don't snap or shake them, and nothing goes on the floor ever. We're going to scoot and roll so the patient's in the middle of the bed at all times. We're going to use our washing rules. We're going to clean our basin. And that's all. That's it for partial bed bath. So everything black. Remember how some of them, it's like half of it's black? Yeah. Look at this. There's not much here for partial bed bath, specific to partial bed bath. Almost everything else is one of the principles that we learn. So even though this is a long skill, it's not a hard skill. Okay. And then of course, we're going to do our closing at the end and get those check marks. Do these help you when I do this? Does this help you kind of visualize? Is this helpful for you? Okay, good. Because you guys are the first ones that get this. Like I said, I just redid all these slides. So this is new. And I'm hoping that it's getting that, making it a little more intuitive for you.
Like the opening, the closing. I mean, it's a lot of it. And if you know those certain things, then it.
Yeah, when you're looking at that, it's like, oh, that's it for,
Right,
for partial bed bath. That's not too much. Now, the other thing that I want you to understand when you're looking at these, right, these big checklists, is the sheer amount of steps. There's a lot of steps here. And that, I think, was overwhelming my students when, you're looking at, if you look in your book on page, 127, 127 and 128, there's a ton of steps there. And I think that was just getting really overwhelming for students. Oh my gosh, I've got how many? It's like 40 something steps. Okay. 47. Yeah, that's a lot of steps, right? And students were just like really anxious and not really practicing this one but almost all of them are these. There's not much that's specific to this particular skill. So you've already we've seen these like over and over and over again. So it shouldn't be too terribly bad for you. That's what I was trying to get across to this, but I need feedback from you guys to let me know that it is. All right. So remember, this care plan is only for this one patient, not for anybody else. One other thing, when you're cleaning a female patient, and this is a female, the mannequin is a female. She is plastic. She's not real, right? So when you're cleaning a real female, the breasts don't stand up usually. So we have to move them to clean under them. When you're cleaning under, when you're moving a female breast, it's best to use the back of your hand to lift rather than the palm of your hand to cup and lift. We don't want to cup. We want to lift with the back. And that just helps our patients feel a little more, there's exactly, even though it is, it's a glove and it is skin, this cannot be construed in any way as a sexual touch. Yeah. Does that make sense? Same thing with male genitalia. To move the scrotum, again, we're not going to cup. We're going to use the back of our hand to lift up and away to clean those creases around the scrotum. Does that make sense? There's no way to say that without, it's an uncomfortable subject, but if I don't address it, then we're going to be doing the wrong techniques out there. Okay. All right. So we're going to go ahead and watch this video. Now, remember that you've got 19 minutes to get this done. Somebody with your level of experience. The video itself only takes, I think, 13 minutes. And remember, I've got the whole introduction and supplies and care plan and all before we even get to the skill. And then I've got the credits, which I don't even show you, which take up another minute at the end. So 13 minutes, you subtract all of that out. I'm really getting this done somewhere around 10 minutes. They give you 19. So you do have enough time to get this done. Don't rush. I think that there's less time for denture care than there is for this. I think they give you plenty of time for this. Good? Good. Okay. So Jake, take it away.
Good morning, Miss Jones. My name is Patty. I'm your CNA today. How are you? Fantastic. I'd like to provide a partial bed bath. Is that okay? Wonderful. I'm going to close the curtain, wash my hands, get my supplies, and I'll be right back. Now that I've washed my hands, I can gather my supplies. I'm going to place the supplies on the overbed table. We'll start with a barrier, unfolding the barrier so the absorbent side is facing up, and this gives us a clean place to put our clean supplies. For this skill, we're going to need 2 towels, 4 washcloths, 1, 2, 3, and 4. I need a privacy blanket and a clean gown. Being careful not to hold the clothing against your uniform. I'll bring this over to the patient area. We'll bring this over here within reach, and then I'm going to get the supplies out of the drawer that I need. We're going to open the middle drawer and remove the basin, soap, and lotion. I'll put these on the overbed table. And I'm going to get a set of gloves. Okay, Miss Jones, I'm just going to get some water in the basin. I'll be right back. I'll use a paper towel to turn the faucet on. Check the water temperature with the inside of my wrist. It should feel warm, not hot, not cold. And we'll fill the basin about a quarter of the way full. Okay, Miss Jones, I have the supplies here. Would you like to check the water temperature and make sure it's okay? It's good? Very good. Okay. So I'll put the washcloths in the water. And the first thing that we're going to do is place a privacy blanket over you. This is going to help keep you warm and provide privacy while we do this skill. We're going to spread this out without snapping it or shaking it. Placing it over the sheet. And I'm going to pull your sheet down to just below your waist. Okay, now I'm going to put the towel on the bed. This is going to help keep your sheets dry, and we'll untie your gown. So I'm going to help you sit up by putting my hand on your upper back, and on the count of 3, we're going to sit. 1, 2, 3. Very good. I'm going to untie your gown. And then we'll spread that towel out underneath the areas that we're going to wash. Come on back. Very good. And I'm going to remove the gown on the side closest to me, supporting at the elbow as I lift. Okay, Miss Jones, go ahead and bend your elbow. Thank you. And then we'll move the gown over to the other side, making sure that you're covered at all times. Now we're ready to start washing, so I'll go ahead and put my gloves on. We'll take the first washcloth, wring it out really well, and then I'm going to hold the washcloth in my hand so the free leaves are at my fingertips and tuck in the 2 side corners. And this allows us to use a different leaf for each area that we're going to clean on the face. After wringing out the washcloth, no drippy wet washcloths, we're going to wash your face first. I'll start with your closest eye, and we're going to wash inner to outer corner using the leaves method, which is going to help prevent cross-contamination. So with the first leaf, we're going to wash the inner to outer corner of this eye. We'll fold that leaf over. And with the second leaf, we'll wash the inner to outer corner of that eye. Fold that leaf over, and with the third leaf, we'll wash the remaining skin of the face. We'll fold that leaf over, and with the last leaf, we'll wash the nose. And we're going to put this on the barrier. Whatever we rinse, we dry. So I'm going to take the towel and fold it around my hand so I have control over it, and I'm going to pat all of those areas dry using short, soft strokes or a patting motion. We'll set the towel aside. Okay, now we're going to take washcloth number 2 and wring it out really well so that it's not drippy wet. And then we'll apply soap to the top leaf. We're going to start cleaning the neck, behind the ears, under the chin, across the neck, the upper torso, down to the breast, keeping the patient covered at all times to protect modesty, down to the belly button, and up the side. Now, for the test, you will keep the patient covered. The evaluator will ask you to move the blanket if they would like to see. I'm going to go ahead and remove the blanket now so that you can see what I'm going to do. So we're going to move the blanket down, and I'm going to start again to show you how to clean the patient. So under the chin, behind the ears, across the neck, the upper chest, around the breasts. When you lift the breasts, we lift not with the palm, but with the back of our hand to lift the breast to clean underneath, down to the belly button, up the side, down the front of the arm, all the way to the hand, supporting the elbow at all times, either with your hand or the bed, up the back of the arm, and we'll clean the armpit last. We're going to set that on the barrier. Whatever we wash, we rinse. So I'm going to get a rinsing washcloth, and we're going to rinse all of those areas the same way. So behind the ears, under the chin, across the neck, upper torso, around the breasts, down to the belly button, up the side, down the shoulder and the front of the arm, supporting the elbow, the hand, lifting the arm from below, washing the underside of the arm and the armpit last. We'll set that washcloth back in the basin for future use. We're going to take the towel, controlling the edges, and we're going to pat all of those areas dry or use short, soft strokes. Nothing vigorous. So the abdomen, down the arm, lift the arm up, support at the elbow, dry the hand, lift the arm to dry the underside of the arm and the armpit. We'll set this aside. Now, the care plan only asked us to clean one arm. So we don't have to go over and clean the other arm. And that's because that's what the care plan instructed. In some cases, you will have to clean both arms. In that case, you would just do that at this time. But for right now, we only had to clean one arm. We did that, so we're going to dress the resident in her gown. I'm going to spread the gown out, put my hand in through backwards on the armhole, lift her hand by holding her fingers together to place the sleeve over the arm, and then I'll lift at the elbow to bring the gown up. I'm going to make sure that gown is covering her. Put the privacy blanket back in place, and now I'll go to the other side of the bed to remove the old gown and put the new one on. Okay, now I'm going to move the blanket and remove the gown from this arm by sliding it off the arm, lifting the elbow from below with a flat palm, and then this will go in dirty linen. Now I can put the new gown on this arm by putting my hand in through the armhole backwards, grasping her hand, and sliding the gown over. We're going to lift from below at the elbow and make sure that the gown is properly in place. Now I'm going to go back to the other side of the bed. Okay, Miss Jones, I'm going to wash your back now. So I'm going to pull you toward me and turn you up on your side, and that way you're in the middle of the bed after the turn. Okay, go ahead and slide toward me. And then you're going to roll on your side. 1, 2, 3. Thank you very much. The evaluator will hold the mannequin in place during your cleaning, during the test. Live patients, of course, can lay on their side. So I'm going to ask the evaluator to please hold the mannequin in place for me. Thank you. We'll slide this towel down so it's covering the bed underneath the back. We're going to take our third washcloth, wring it out really well, and we'll apply soap to the top leaf. I'm going to wash the back from the neck down to the shoulders, all the way down to the waist. We'll set this washcloth aside, and we'll get our rinsing washcloth. So we'll wring that out, and we'll rinse the same way we washed. The back of the neck, the shoulders, all the way down to the waist. We'll set that aside, and we'll take our towel to dry those areas. So I'm going to pat dry or use short, soft strokes and dry all of those areas. Now the care plan asks me to provide a brief back rub. So I'm going to take my lotion, put a little bit in my hands, and then I'm going to warm it up by rubbing my hands together. We're going to start at the base of the back and go up in small circles to the shoulders, and we'll do this 3 times. To the shoulders, come down, up to the shoulders and come down. And then we'll take the towel and wipe off the excess lotion. We'll remove that towel from the bed, putting it on the overbed table, and then we'll tie the gown. Come on back, Miss Jones, onto your back, and then scoot to the middle. Thank you. Okay, you're covered and safely in the middle of the bed. Let me go dispose of all of my supplies, and I'll be right back. So I'm going to put all of the supplies in dirty linen, being careful not to hold them against my uniform. And now I'm going to clean my basin, and we'll dispose of the water in the sink. Rinse the basin, and then dispose of the rinse water into the sink as well. I'm going to set that down, disinfect it per facility policy, and then pick it up with a paper towel. I'm going to get a clean paper towel to dry the inside. I'm going to get a clean paper towel to dry the outside. And then one more for the drawer. Okay, on the way, I'll place the lotion and the soap into the basin using a paper towel. And then I will use the paper towel to open the middle drawer and slide the basin with the soap and lotion into the drawer. We'll close the drawer with a paper towel and then throw them away. I'm going to remove the barrier, throw it away, and then I can remove my gloves. Okay, Ms. Jones, I'm going to move your privacy blanket now. So as I pull the blanket up, I'll restore the sheet. This preserves modesty and keeps the patient warm. We'll roll the privacy blanket up in a ball so that trailing edges don't contaminate other surfaces. Okay, I'm going to place this in dirty linen. We'll return the table to storage. Adjust the sheet for neatness and appearance. Okay, Miss Jones, are you comfortable? Is there anything else I can get for you while I'm here? Okay, let me place the call light in your hand. So there you go. The call light is in your hand. If you need anything at all, please press that red button. We'll be happy to come help you. Bed is in the low position. The environment is clean. I'm going to open your curtain and go wash my hands. After washing my hands, I'll review the care plan to make sure that everything in the care plan was addressed with this skill. I'll think about my skill and make any corrections that need to be made. And once I'm happy, I'll tell the evaluator my skill is done.
All right. We have a question. Are you not using lotion on their hands and chest and face? No, because the care plan says back rub with lotion. So if the nurse wanted lotion on the rest of the body, the care plan would have indicated that. Good question. Good question. Any others?
I have a question. So I know you had the privacy blanket down to show what you were doing, but when you're putting the gown on the resident, the privacy blanket's up, right?
Yeah, you really should have the patient covered as much as you can. You're going to have to move it to, to work around. In most cases, I do this like I do dressing a resident. Remember with dressing a resident, I had the privacy blanket kind of propped up over their chest and I put the clothing on over and then just took the privacy blanket off after the clothing is. I would do the same thing here. So I would put the gown on over the privacy blanket, get their arms in it, and then once they're covered, I'll pull the blanket down. Yep. So kind of the same scenario.
So only one washcloth that I use for the face, and the rest 3 is for the body.
Right. So washcloth 1 for the face, set it aside. Washcloth 2 washes the front, set it aside because it's got soap on it. Washcloth 3 rinses the front. We can reuse that. Turn them over. Washcloth 3 is gets soap and now it washes the back. Set that aside. Washcloth 4 rinses the back. Any other questions? Okay, you guys have 40 minutes of practice time in class today. So I'm so glad I redid these slides because we never had practice time on class 5. So I'm finally dialing in the timing here for you. So before we get to practice, your homework tonight is chapter 7. It's another skills chapter. Read the paragraphs in between. You're going to take the test on page 187 of your skills book. You'll get the wrap-up emails. Everybody getting the wrap-up emails? Make sure that you're making flashcards for your supplies if you haven't purchased ours. And the replay of today's class will be available for you as well. So CPR, Julie's the CPR instructor. Give a wave. She teaches, this is her classroom. She teaches in this classroom and she has a special rate just for you guys. So if you use that QR code, it's on the blue paper that you got on day 1 and you've had it in every class since. But if you scan that QR code, it'll bring up the special rate for you. You don't need CPR for the test. You do need it to work. So get with Julie. And Jake's going to pass out the review sheet. And we're going to go ahead and say goodbye to all of our watchers online. Thank you so much for joining us. Tomorrow's the game show at 11. Make sure that you set your alarms and compete to win prizes, answering real test-like questions. Hope to see you there, 11 a.m. Go directly to my YouTube channel for that. So youtube.com/foryourCNA. And then we'll see you back here on Wednesday for class 6. We're almost done with week 3. 3 classes left, guys. It's going quick. It's going quick. Until next time, happy caregiving. Bye.